One, please start, sir. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on current treatment paradigms, management of breast and lung cancer. And with immense pleasure, I would like to invite Dr. Priyanshu Choudhary, who is consultant medical oncology, Shalby Hospital, Mohali, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Hi, thank you, ma'am. A very good evening to all of you. I, Dr. Priyanshu, and Dr. Piyush, consultant medical oncologist in Mohali, we welcome you all today for this symposium on breast and lung cancer treatment paradigm in 2022. And as we all know that breast and lung cancers are the most common and important cancers we treat in our practice. And fortunately, both of these have shown tremendous change in the landscape, in the treatment landscape in the last decade or so. And so much progress has been made in these cancers that we are now talking about 5-year overall survival data in lung cancers. So we'll be discussing hormone receptor positive and HER2 positive breast cancer treatment options today. So because of paucity of time, we won't be having a discussion on TNBC. And in lung cancer, we'll be discussing non-EGFR driver mutation cancers, lung cancers, and immunotherapy in lung cancers. So as a young medical oncologist, we are still in the beginning of the learning curve, and a personal experience and guidance from the senior medical oncologist would go a long way in helping us. And so we might not have the clinical experience of all the newer molecules which we have, so we'll be sharing our experiences. And so we'll be looking forward for all the panelists to share their experience. And so let's start this session today. And over to you. So for the first session, can you introduce the speaker?
So today's first session, I invite the speaker, Dr. Anurma, who is HOD Medical Oncology and Hematology, Patel Hospital, Jalandhar, and she is going to talk on optimizing therapy in HER2 positive breast cancer, newer paradigm shift in cancer care. Over to you, ma'am.
Thank you. I hope I'm audible, and good evening, everyone. So I'll just share my screen. Okay, great. I hope it's all visible to everybody.
Yes, ma'am.
I will be talking a little bit about a new product that I wouldn't say it's old. I would say maybe a product that all of us are quite familiar with now, but being the science has advanced that product, I would say, a little bit further so that it gives more comfort and more quality of life to our patients. And that new product, which hopefully we will be able to use soon, is Phexo, which is a fixed dose combination of pertuzumab and trastuzumab in subcutaneous form. These are the disclaimers. And at the outset, I will say I have not used this product as of now. And if maybe some of the faculty has used it, we will maybe get their experience at the end of it. But I do look forward to using it soon. And therefore, this was a good, I would say this is a good overview of the product and how to use the product for all of us who, in our, who are all practicing clinicians. So all of us are, quite comfortable, quite familiar with the standard of care for HER2 positive breast cancer, both in the neoadjuvant, adjuvant, and metastatic setting, where the combination of pertuzumab and trastuzumab with chemotherapy has really transformed patients' life, I would say, has given us better clinical outcomes. In the neoadjuvant setting, this combination with chemotherapy has shown to have an improved path CR. In the adjuvant setting, trastuzumab plus pertuzumab plus chemotherapy reduces the risk of recurrence or death as compared to trastuzumab and chemotherapy alone. And we are all familiar with the Cleopatra study that showed almost an increase of 12 to 13 months PFS, and almost 6.5 months increase PFS from 12.4 to 18.5 with the combination combination of targeted agents and chemotherapy as compared to just the single targeted agent with chemotherapy alone. And the difference in median overall survival was 16.5 months. So none of us are denying that this combination has huge clinical benefits to our patients, but we also all recognize that there are several challenges to treating our patients with this combination. And just a short look at the algorithm the algorithmic approach that we all use when we're seeing a newly diagnosed patients with HER2 positive early breast cancer. Most of us, if the tumor is more than 2 centimeters or node positive, will apply a new adjuvant approach where we would give the combination along with chemotherapy for about 4 to 6 cycles, then surgery, and depending on whether there is residual disease or not, if there is PAT-CR, most of our patients would go on to just the maintenance therapy alone, but if there is residual disease, then they would use the alternative agent of TDM1. So by and large, I would say most of our patients should fall into this side of the algorithm, because very few of our patients are really picked up when the disease is less than 2 centimeters. But if they are, then most of them would then just go ahead for surgery. And if they have, less than 2 to 3 centimeters tumor with no lymph nodes, I have also changed my practice. I just give trastuzumab paclitaxel combination followed by trastuzumab maintenance alone. But if there are some, surprises in the surgery and the disease is more than what we thought it was initially and it's lymph node positive, then of course we would do the full adjuvant therapy of ACTHP followed by the maintenance therapy alone. But like I said, there are several challenges because the combination of pertuzumab and trastuzumab leads to long, I would say, chemo chair time, because each infusion, pertuzumab over 30 to 60 minutes, followed by an observation of 30 to 60 minutes, depending on whether you're doing the maintenance or loading, and trastuzumab. Generally, the first infusion over 90 minutes, and then if they tolerate it well, 30 minutes in the maintenance setting. And there too, you have to observe the patients for anywhere between 2 to 6 hours. So preparing these drugs takes longer. And we all know that most of our patients' veins kind of give way. And in fact, if a patient is HER2 positive, at the outset, most of us would tell them to get a chemoport or a PICC line. That itself has its challenges, especially in our country. I would say the care of the PICC lines and the increased risk of infections that we see in patients who have a chemoport or PICC line is well established. And sometimes we have to pull out the indwelling catheter. It is not a very easy thing for the patient, and not only does it come with increased costs, increased time in the hospital. A number of difficulties are there, and that's where we come up with this combination. I think this is like this novel formulation, I would say, because this is the first formulation of 2 monoclonal antibodies, both pertuzumab and trastuzumab, in a single vial for subcutaneous injection. We know that trastuzumab had already received approval for subcutaneous injection prior, but till this combination was introduced, of course, pertuzumab was not being used in subcutaneous formulation. So this combination contains the same antibodies that are approved for intravenous pertuzumab and trastuzumab. The new thing, because one of the first things that comes to our mind is, when you give a subcutaneous injection, especially if the volume is higher, how does that disseminate from the subcutaneous area to the IV? And my biggest concern actually when I was going through this was, does it leave a large, like a bump or a lump under the skin? So the reason why it does not is because it's formulated with recombinant human hyaluronidase that allows the sub-Q administration and allows I would say, the dissemination of the drug fairly rapidly. And the biggest advantage, of course, of the subcutaneous injection is that it really brings down the time for administration of the monoclonal antibody. If you're giving the loading dose, which we will come to the doses in that. But anyway, loading is over 8 minutes, and it's about a 15 ml solution. And if it's a maintenance, it's about a 10 ml solution, which is over 5 minutes. We are all familiar, I would say, with the mechanism of action of pertuzumab and trastuzumab. We know that it is designed for dual HER2 blockade, and the site of action or at the HER2 level, at the molecular level, is different. The trastuzumab site is a little bit closer to the cell membrane, and the pertuzumab site of attachment is actually at that part which is involved with the dimerization. So when pertuzumab gets attached, it improves the effect of the trastuzumab and decreases the HER2 signaling. So what hyaluronidase does is it allows this delivery of larger drug volume. It increases the permeability of the subcutaneous tissue, and the effect is fast, and it's also reversible. So the permeability of the tissue is restored within 1 to 2 days, and there is no lasting, I would say, damage or side effects because of the addition of the hyaluronidase to this combination. So just again, what is the reason that this formulation has this third agent in it is because it allows for the dissemination of the drug. Okay, so this is again what I was talking about, is that if you give a bolus in the subcutaneous region without this recombinant human hyaluronidase, you will be left with the drug will stay here, and the patient will have like this large lump under the skin. But when it is combined with this, as you can see in the pictures, there is nothing there's no residual lesion or lump or something in that area, and there is no discomfort per se to the patient subsequently. And of course, the first question that comes to all the clinicians' mind is the effect or the pharmacokinetics, the efficacy and safety of this subcutaneous fixed drug concentration of pertuzumab, trastuzumab the same or equivalent as giving it IV? And to answer that, we will go through how the drug development took place and what were the studies that looked at not just the efficacy, safety, but also patient preferences. So the dose finding study was this phase 1B study, which was divided in 2 parts. The first part was on healthy male volunteers to determine what would be the adequate dose. So it was a dose finding. The part 1 was dose finding. And the second part was in patients with early breast cancer. And again, it was the dose confirmation part of it. And at the end of the phase 1B study, they found that, and they selected a loading dose of 1200 milligram of pertuzumab and a maintenance dose of 600 milligram of pertuzumab. The dose of trastuzumab does not differ. It remains 600 even in loading dose, in the loading dose, and 600 in the maintenance dose. So when we talk about, there are 2 vial sizes for this Fexo. The first one is 1200 plus 600, which is your loading, and 600 plus 600, which is your maintenance. And like I said, the volumes are different. The loading dose is 15 ml and the maintenance dose is 10 ml. So when in this, they found that there were no new safety signals. And following this, they went to the phase 3 study to look at the pharmacokinetics, efficacy, and safety of this combination. And in this, patients were about, I believe, 500 patients who were randomized 1:1 to get the chemotherapy, which could either be dose-dense AC followed by paclitaxel, or AC 3 weekly with docetaxel 3 weekly. And the 2 arms were pertuzumab and trastuzumab given intravenously, followed by surgery, and then the maintenance part of it, or this the trastuzumab and pertuzumab given as this fixed drug combination, the subcutaneous Fexo. And in the maintenance part, also the patients who received IV, they continued on to get IV, and the patients who received subcu continued on to get subcutaneous. The primary endpoint was non-inferiority of cycle 7 trough levels. And the reason they chose cycle 7, which when I was looking at this, was because cycle 7 is cycle 8. The patient then is coming back for after cycle 8, if you assess the level, the patient is already going to the surgery route. So then you have to call the patient back. So just before the last dose in the neoadjuvant setting, which was cycle 8, they would be measuring the trough levels. And the reason why they chose trough levels was because it had more implication on the overall clinical outcomes as compared to the Cmax. And the secondary endpoints were basically PAT-CR, safety, overall survival, invasive disease-free survival, etc. Again, just to look at the pharmacokinetic endpoints, because that shows us the bioequivalence between the subcutaneous dosing versus the IV dosing. So when we give a drug IV, the Cmax is immediate. So all of the drug goes into the circulation, and it is not subject to distribution and elimination effects. But when you give it subcutaneously, it will take some time for it to disperse from there and reach the bloodstream, and then gradually a steady state will be reached. And as you can see here, with this combination, the trough level of the subcutaneous is actually a little bit higher than the trough level when you give it IV. And the trough levels don't correlate with outcomes as much. The Cmax levels don't correlate with outcomes as much as this trough level, which is the minimum concentration that you reach just before the next dosing. And of course, when they looked at the primary endpoint, this trough level, it was, in fact, like I told you, the subcutaneous trough levels were a little bit higher, and it exceeded the non-inferiority margins. And the secondary endpoint, so the pertuzumab trough level was the primary endpoint, and the trastuzumab trough levels were one of the secondary endpoints, and both the endpoints were met. When we look at PathCR, it was equivalent. 59.5, which is 60% in the intravenous, the patients given intravenous formulation versus 59.7, those patients who were given subcutaneous formulations. So exactly the same. Now, they also looked at PathCR by body mass index, and this is quite interesting and I would say intriguing for us, because there is a wide variation in the Indian population also that we see. Punjab, we see more overweight patients with breast cancer, and I guess the other areas that's not so much. But what they found, and this was again interesting, is that the weight is inversely correlated to the PathCR. So a patient who is underweight will metabolize these faster. And when they looked at this, they found that patients who were underweight, the PathCR was 100% as with the IV formulation, but lower with the subcutaneous formulation, because that patient is metabolizing the drugs faster. Now, the authors, though, they said that because the numbers were so low, they did not really make any change out of this. And what they said is that people always question that when we are used to dosing the chemotherapy according to the weight and BSA, but here because the metabolizing of the drugs depends on your weight, even though you're giving the same dose, ultimately the levels in the bloodstream are more or less the same. So that is why the dosing is across the board same, because probably our weight influences how we use up these drugs. The safety profile, again, adverse effect, any adverse effect were almost 100% in both the IV and the subcutaneous arm, and grade 3 side effects were about 50% in both the arms. There was one death in each arm, and in fact, a little bit more patients discontinued the treatment due to adverse effects in the IV arm as compared to the subcutaneous arm. And so, quite well balanced: alopecia, nausea, diarrhea, anemia, asthenia. And again, this is kind of also reflecting our chemotherapy, side effects, because it's not just the side effect of the monoclonal antibodies. And there was no increase in cardiac dysfunction, even though the doses were higher, because remember, the overall levels in the bloodstream were not that much higher. There was no increase in neutropenia, diarrhea, mucositis, ILD. There was little difference, about 3 to 4%, in the infusion-related reactions, and the authors claimed that this was probably because even slight pain or redness at the infusion site was counted in this. So maybe people were a little bit more apprehensive about using this, and were more I would say, sensitized to recording any side effect that the patient suffered. And again, no difference in cardiac safety. So at the end of this, what they were able to prove is that the fixed dose combination subcutaneous of pertuzumab, trastuzumab was non-inferior to the combination given intravenously based on the cycle 7 C trough concentrations. They showed that the PathCRs were equivalent, And they also showed that the safety was comparable and there was no difference really in safety. So this phase 3, I would say, was a successful trial, and it led basically to the approval of this combination. Now, what about patient preferences? Because we all recognize that patient preferences is very, very important when we talk about giving any treatment. And I would just say, all of us now use bortezomib sub-Q, and when it was just introduced, we were using for patients with multiple myeloma IV, and we all know that sub-Q, giving sub-Q is faster and so much more easier, and patients are much more comfortable. So what about patients getting the subcutaneous formulation in breast cancer? And for that, they did a 160 patient study where patients with early breast cancer were getting the maintenance part of the pertuzumab and trastuzumab. And what they did in this study is they randomized into these two groups, where first the patient got 3 cycles IV, then they got 3 cycles subcutaneous. In the other arm, it was subcutaneous first, followed by 3 cycles IV. And then the patient selected what they wanted to get going forward based on what they saw in their experience with the IV and the subcutaneous parts of the initial portion of the trial.
My apologies, ma'am.
I have a few minutes.
My apologies, ma'am. You are left with 2 minutes to conclude your presentation. 2 minutes, ma'am.
Okay, sure. So the preference in this study was very, very strong, I would say, for the subcutaneous. 88%, 87% overall at the end of the day chose this combination of subcutaneous formulation to continue going forward in the maintenance part of it. And the reasons that they claimed was, of course, less time in the clinic and much more comfortable administration. And even the physicians and the healthcare providers, they also preferred giving the subcutaneous route as compared to the IV route, because it was quicker, less resource usage, and less drug wastages. Again, the adverse events were same, and there was no new safety signals. And most of the patients were very satisfied with 85% preferred getting the subcutaneous over the IV formulation. So I think that this is really a good thing for most of our patients. We just have to probably train and make sure that our oncology nurses are comfortable giving this combination. The patient is supposed to sit in a chair, and you only give it in the thigh. You're not supposed to give it in the abdomen, because the pharmacokinetics are lower if you give it in the abdomen. So that's just one point to be very careful about. And you alternate the sites every time, and you can't split the doses or give it at 2 different sites whenever you're giving this. Just supposed to be given slowly. We already talked about 8 minutes for the loading dose, followed by 30-minute observation, and for the maintenance to be given over 5 minutes, followed by a 15-minute observation. And I would say, probably in conclusion, this formulation is the first formulation of 2 monoclonal antibodies that giving in a subcutaneous form, it is a faster and less invasive method, and with equivalent clinical outcomes, and both in terms of the concentration, the pharmacokinetics, and the PAT-CR, but better patient preferences and preferred by patients. So probably going forward, I guess, given a choice, probably most of our patients would also prefer to use the subcutaneous formulation. Thank you.
Thank you, ma'am, for enlightening us with this new drug. And I think if anybody has any question, they can ask. Dr. Piyush, you have to unmute yourself.
So should I invite next speaker, sir, now?
Dr. Piyush has, I think, so a question. It is not.
Okay.
Yes, he's still muted. Ma'am, I have a question. Like, if somebody has, grade 3 or 4 diarrhea, and with pertuzumab, so we try to reduce the dose, but it's very difficult to do that in a case with a fixed dose combination. So, do you think that's one of the drawbacks with this combination?
I guess that could be one of the drawbacks. I have not very frequently, I mean, again, I would welcome your experience and everybody else's experiences. I very rarely had it to reduce doses though. I would either just hold, probably in this combination, if you're using it you might end up holding it if you wanted to for that time and just giving the trastuzumab sub-Q, or sub-Q is not available right now, so maybe IV, but I don't know. How frequently have you had to hold the drug or decrease the drug? I've not had to.
I had few patients with on neoadjuvant therapy. I had 2 patients who had actually grade 4 diarrhea, so I had to stop it, and the patient was taken for surgery, and both of them had a path CR actually. So,
but was it because of the you think it in neoadjuvant, you are giving chemotherapy also?
Yeah. So definitely that's one of the things. That was one of the confounding factors, but definitely I think so. Diarrhea I have seen a lot. Grade 3, 4 probably less, but yeah.
Actually, for me, the biggest thing was to get my head around a little bit was how that whole thing about weight really confounded me a little bit. That was for me a little difficult thing to wrap around. How they showed about the metabolizing and all that, because giving the same weight, of course, when we give pertuzumab, even IV, it is the same weight.
It's the same, yeah.
But still, to understand that thing about underweight people having like fast metabolism of the sub-Q, and that's why the doses were lower. So that was a little, but again, the authors said, and I heard the international speaker, and they didn't seem to draw a lot from it. And they said the numbers are so low, you can't make any conclusion.
Exactly. Okay. So I think so we'll be starting the next session. Thank you, ma'am. Thank you so much for this talk. And I think probably a few months down the line, we'll be using this and we'll be more experienced with this. So now I would request Dr. Piyush to give his talk on advancing the management of HER2 positive breast cancer. Over to you, Dr. Piyush.
I would like to invite Dr. Piyush Mehta, who is consultant medical oncology, and is going to talk on new treatment approach in management of HER2 positive MBC first line and beyond. Over to you, sir. Dr. Piyush is muted. So, Surbi, can you call?
And he is unmute. Sir, can we share your slides? Piyush sir, we are. Hello. Sir, we can't hear you.
I'm calling him. So, can you share the slides of Dr. Piyush?
Sure, sir.
Yeah. So he's logging out and logging in again. So by the time we can share the slides.
Hello. Hello.
Yes, Dr. Piyush, we can hear you.
Audible, sir. Sir, please say
Okay.
next when you want to change the slide.
Sure. So good evening, everyone. So I will be talking about the treatment of both HER2 positive, early, locally advanced, and metastatic breast cancer, which are HER2 receptor positive, HER2 positive. So as we know that breast cancer, that is the most frequently diagnosed cancer, and it is a cause of cancer-related death among females worldwide. And in the United States, around 5% of the women they are diagnosed with breast cancer have, in their lifetime. And these patients, they are more 5% are metastatic at the time of their presentation. And despite the gain in the early detection, even 5 to 10% of patients are diagnosed which are in the stage 4 disease. And 30% of the women who are in the early stage non-metastatic breast cancer, they will ultimately develop metastatic disease. So, and in all the cases, in all the patients of breast cancer, around 20% of the patients, they are positive for HER2 receptor, HER2 positive. And now I'm giving a brief review regarding the HER2 directed therapies which are available and when to use them, how to combine them, and what are the indications of all of these therapies. And we as know that high level of the HER2 expression or the overexpression that is determined by either a 3+ staining on the IHC, in which we detect the HER2 protein, or the evidence of the HER2 gene amplification by FISH, in which a FISH ratio of more than or equal to 2, we consider that as a positive and likely that patient that is a strong predictive value in the treatment of a HER2 positive cancer. And all of the patients who don't express HER2, they will not benefit from any of these. And in case of a metastatic disease, biopsy of the metastatic site that is recommended as uh, the marker status, hormone receptor positive or negative or HER2 positive, that can change when even the disease become metastatized. Now, the various drugs which are available for targeting the HER2 are the trastuzumab, pertuzumab, TDM1, and tucatinib, neratinib. So now I'm going to start with the neoadjuvant chemotherapy. It's a phase in the neoadjuvant setting. I'm going to start with it. It's a phase 3 train 2 trial in which neoadjuvant chemotherapy with or without anthracycline that was done with dual HER2 receptor blockage in metastatic so it's in a neoadjuvant setting in the early breast cancer. So it was a phase 3 trial which was open label randomized, and the patients with HER2 positive early breast cancer, stage 2 and 3, and no previous therapy, with performance status of 1, 0, or 1, and with left ventricular ejection fraction more than 50%, they were randomized to 3 cycles of TCHP, followed by 6 cycles, followed by surgery. And in the another arm, they've given 3 cycles of 5-FU apiribicin based treatment and the trastuzumab with pertuzumab, followed by 6 cycles of TCHP. And then after surgery was done, and they completed adjuvant trastuzumab for a total of 1 year. And in this, the primary endpoint, that was the PCR, that is by local assessment, and the secondary endpoint was the overall survival and the relapse-free survival. Next slide, please. So in this trial, the primary endpoint of PCR, like we have seen that higher rates of PCR, they are seen even with or without anthracyclines, and they were almost similar. Like as we can see that out of 206 patients who were in the arm in which they have used TCHP, the PCR rate was around 68%, and in the another arm it was around 67%. So the main outcome that was consistent across all the levels of the pre-specified subgroups, and that is there is no difference, and there was no difference in the event-free survival or the overall survival. Next slide. And in a safety profile at the 3 year of a follow-up, we have seen that in the arm where we have used TCHP, where the neutropenia that was in 54%, and in the another arm it was 60%. So this is a comparison of the different side effects profile in both the arms. And anemia, it was almost similar in both the arms. Thrombocytopenia almost similar. But the incidence of febrile neutropenia, that was more in the arm where we have used epirubicin 5-fluorouracil. And the non-hematological side effects, they were like diarrhea, hypokalemia, diarrhea, and that was more in the TCHP because of in the TCHP, and the hypokalemia that was more in the 5-FU group. Neuropathy almost similar, fatigue almost similar, but these are the main side effect profile. But as we can see that the left ventricular ejection fraction in the TCHP, there was a decrease of more than or equal to 10% in 22% of the patients, and it was more in the another arm of in which 5-FU was used. It was 36%. Next slide. So this is affinity trial. It was a phase 3 trial, placebo-controlled trial, in which pertuzumab along with trastuzumab and chemotherapy versus single, the no pertuzumab. That is trastuzumab and chemotherapy in HER2-positive early breast cancer. So it was an international randomized double-blinded placebo-controlled phase 3 trial. In surgery, the patients with HER2-positive breast cancer, they were randomized to receive chemotherapy along with pertuzumab and trastuzumab in one arm, and chemotherapy with trastuzumab and placebo in another arm. Treatment was completed for a total of 1 year, and in a 10-year follow, the primary endpoint was IDFS. Secondary endpoint was IDFS, OS, distance-free recurrence survival, DFS, cardiac safety, health-related quality of life. So these were the secondary endpoints. Next slide. So as we can see that in the 6-year follow-up, the safety and we can see that there was no difference in the fatal adverse event in both the arms, pertuzumab as well as in the another arm. But we can see that more primary events in cardiac events, they were more with the addition of the pertuzumab, that was 0.8% versus 0.3% with the placebo. And as we can see that with the addition of the pertuzumab, the overall survival rate that increases. Next slide. So Catherine trial, in which TDM1 was used versus trastuzumab in adjuvant therapy in HER2-positive breast cancer. Patients were given neoadjuvant treatment, trastuzumab surgery we see for the PCR, and in case they do not change the PCR, we divide them into either the TDM1 in a dose of 3.6 milligram per kilogram 3 weekly for a total of 14 cycles, or trastuzumab 6 milligram per kilogram 3 weekly for 14 cycles. And next slide. So in this, we can see that in the primary IDFS, in the TDM1, it was 12.2, and the distant recurrence, that was more in the trastuzumab, it was less with the TDM1. Locoregional recurrence, that is also less with the TDM1, and control cancer, that was also less with the TDM1. So CAN trial, that becomes a landmark of using this TDM1 in this setting. Next slide. Next slide. So all the adverse in more than 15% of patients in either the arm. So we can see that in the TDM1, there was more fatigue, more nausea, thrombocytopenia is more in this arm, and increase in the liver enzymes transaminitis, that is more, and skin in this year epistaxis, that is more, increased risk of bleeding with the TDM1 also in some patients, more constipation, more neuropathy. So these are in the TDM compared to the trastuzumab group. Next slide. Yeah. So that there is a 5-year update. So it's a neratinib versus placebo after using adjuvant trastuzumab in HER2 positive breast cancer for 1 year. So in this stage 1 to stage 3 patients, they were enrolled after trastuzumab. Less than 2 years, they were randomized to receive the neratinib versus placebo. And the primary endpoint was IDFS at 2 year, and the primary analysis at 2 year IDFS rate neratinib was 93.9% with placebo of 91.6%. Next slide. So this is extra. It's a 5-year IDFS analysis. As we can see, there was almost similar. Next. 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 Yeah. In the next slide. Yeah. So this is a fixed dose subcutaneous combination of pertuzumab, trastuzumab in HER2 positive early breast cancer that has covered by the ma'am also previously. So next slide. So HER2 positive, HER2 targeted therapy and early breast cancer. So the adverse events are that with trastuzumab, pertuzumab. So it's cardiac toxicity, which is rare. Common is a diarrhea, which is quite common. That is seen in around 30 to 40% of the patients on this combination with pertuzumab mainly. And infusion reactions rare. Neratinib, mostly GI side effects like diarrhea, rash, and liver toxicity, cardiac toxicity, that is rare with this. And there are some drug interactions with the neratinib, and the TDM1 that causes more of a thrombocytopenia, transaminitis, neuropathy, cardiac toxicity, and the liver toxicity, and then infusion reactions, which are rare with this drug. So next slide. So this is a diarrhea outcomes. As we know that a neratinib that causes primarily GI side effects. So we can, as per the, need to start with a lower dose, say 120 per day for day 7. If patient tolerate, then 160 milligram. Then gradually we need to increase the dose. And the incidence of diarrhea with neratinib is around 40%. But if we use the prophylaxis for diarrhea, then the incidence that drops to around 5 to 6%. So we can use loperamide along with this also as a prophylaxis for diarrhea. Next slide. So consideration for management of a neratinib-induced diarrhea. So neratinib strategies at time of initial therapy. So we need to start neratinib at a lower dose and gradually titrate it up. And to use loperamide at the first dose of a neratinib, dose modification, it's based upon the grading of the diarrhea. If the diarrhea persists, then in the grade 4, if the grade 4 diarrhea, then even we need to discontinue the therapy. Next slide. So this is WSG ADAPT TP. It was just presented in the ESMO in 2021. It's a basically de-escalated neoadjuvant TDM1 with plus minus endocrine therapy versus trastuzumab plus endocrine therapy in hormone receptor positive and HER2 receptor positive early breast cancer. So it was a phase 2 trial, small number of patients, 375 patients were enrolled. Primary endpoint was PCR, and with TDM1, the PCR was it was 41%, and with TDM1 endocrine therapy, it was 41%. With trastuzumab with and ET, it was 15%. And there was no difference in the overall survival in this group. Next slide. So Compass HER2, it's a neoadjuvant TH. We have given THP and adjuvant HP in patients receiving PCR. So it was a phase 2 trial again, and THP 4 cycles. Taxane used was either paclitaxel or docetaxel or nab-paclitaxel, and then along with the dual HER2 blockage, we assessed for the PCR, and the primary endpoint was relapse-free survival for 3 years. Secondary was IDFS, DDFS, and the overall survival and EFS. Next slide. Next slide. So these are the ongoing trials in HER2 positive early breast cancer. Like I am patient 5th year using atezolizumab, and then there are trials with TCHP versus TCHP plus atezolizumab. So these are the ongoing trials. These are all other phase 3 trials. The Destiny, Destiny 11, Estefania. Next slide. In HER2 positive metastatic breast cancer treatment approach. Next. So yes, Cleopatra. So as we know that Taxane along with HER2 blockage, dual HER2 blockage in HER2 positive metastatic breast cancer, we can see in this curve, in this Kaplan-Meier curve, that the median overall survival that were with the dual blockage, it was 57, and without it's 40. So, and the PFS in this intention to treat population with the triple drug it's 18.7, and with dual blockage it's 12.4. So it's a significant. Next. Amelia and Theresa. So it's TDM1 as a second line therapy for HER2 receptor positive metastatic breast cancer after progression on HER2 targeted agents. So Amelia, so it was a randomized trial. It was a phase 3 trial in which TDM1 that was in the one arm, and in the another arm there was lapatinib and the capecitabine for HER2 positive metastatic breast cancer with progression on the trastuzumab. So we are giving it on the second line, and median overall survival with TDM1 that was 30, and with the lab cap it was 25.1. And then TH3 research trial, it was a phase 3 study of TDM1 versus chemotherapy of physician choice. TDM1, with TDM1, the overall survival is 22 months, and with another drug of the physician choice, it was 15.8 months. So next slide. Yeah, Destiny, it was a trastuzumab deruxtecan versus TDM1 as a second line therapy. So it was an open label phase 3 study in which patients with unresectable metastatic HER2 positive breast cancer who were previously treated with trastuzumab in the advanced or metastatic setting, they progresses, they were randomized to receive either trastuzumab deruxtecan or trastuzumab emtansine. A median follow-up, we can see that the primary endpoint was PFS, and secondary was overall survival, and the interim PFS it was available in the mid 2021, and so it's a median just follow-up of in the both the drugs is 16.2 and the TDM1 is 15.3 months. So next slide. Next slide. So in the Destiny, when the in this subgroup analysis, we can see that all there were. This is as per the hormone receptor status and prior treatment with pertuzumab, any visceral disease, and with the prior lines of the treatment, and the patients with the involvement in the brain. So these were the patients who were taken, and the median PFS with the hazard ratio at this point towards in the favor of the trastuzumab deruxtecan. Next slide. So PFS by investigator assessment, as we can see that with deruxtecan, the median PFS was 25, and with TDM1 it was 7. And OS, it's early data. It's a median OS. It's still not mature, but the 12-month overall survival that was 94 and 86 in the TDM. Next slide. So it was a safety and adverse event. Like we can see that any drug-related adverse effect more than or grade 3, they were more in the trastuzumab deruxtecan arm compared to the TDM1. And drug-related side effect which led to discontinuation of the treatment, that was more in the trastuzumab deruxtecan, and no deaths in both the arms. And the most common adverse event associated with this trastuzumab deruxtecan is an interstitial pneumonitis, interstitial lung disease. With TDM1, it's thrombocytopenia. And the most common adverse event associated with dose reduction in the deruxtecan, it's nausea, neutropenia, and in the TDM1, it's transaminitis and thrombocytopenia. no grade 4 or 5 events of drug-related interstitial pneumonitis or decrease in the LVF in this group. Next slide. So in HER2-CLIMB, these three drugs are combined: tucatinib, trastuzumab, and capecitabine in previously treated patients HER2-positive metastatic breast cancer. And it was a phase 2 trial. Patients with brain mets, they were allowed in this, and tripled the combination: tucatinib 300 milligram twice a day, trastuzumab, and capecitabine 1000 milligram per meter square BD dosing. That was compared with the trastuzumab and capecitabine and placebo. And the primary endpoint was PFS in the 480 patients which were taken in this study. And the secondary endpoint was OS and PFS in patients with brain mets. Next slide. So we can see that the median PFS with tucatinib with the triple drug combination, that was 7.8 months, and with 1 year PFS, that was 33, and with the placebo it was just 12. So it's a significant. So there's a decreased risk of progression, in particularly in the patients as the patients with brain mets, they were also included in this study. So next slide. In patient with brain metastasis, we have taken that with the triple drug combination, the median overall survival is around 22 months, and in this another arm, that is 17, with the 2-year overall survival of 45% and the 27% in dual drug combination. Next. So overall survival in all patients with brain metastasis, so as we know that triple drug, that is a better median overall survival and improved overall survival with longer follow-up, and 12 months previous analysis was at 18.1 versus 12 months. Next slide. So overall survival in patients with active brain metastasis. So as we can see that the was overall survival in patients with active brain metastasis versus with a stable order treated brain metastasis. So the difference is more, and triple drug combination that favors performs better compared to the dual drug combination. Next. So this is HER2-CLIMB CNS PFS in patient with brain metastasis. So the patients with brain metastasis, as we know, it was tucatinib, trastuzumab, capecitabine, significant p-value, median PFS 9.9, and with active brain metastasis, tucatinib, and it was 9.6, almost similar. With stable brain mets, it was 13.9. CNS PFS benefit in patient that was maintained in the tucatinib arm with a longer follow-up even. Next. So intracranial overall response and duration of response in patients with active brain mets. Patients with complete response or partial response, there were 26 with tucatinib arm, and in the another arm, there were just 4 patients. And patients with next slide. So the most common adverse event, there was diarrhea, PP syndrome, nausea, fatigue, stomatitis, loss of appetite. Next. Is the NALA. So it's a neratinib versus capecitabine, and neratinib with capecitabine versus LabCap in HER2-positive MBC with more than prior 2 lines of a therapy with HER2-targeted agents. So it was a phase 3 trial. It was an open-label trial, and the patients with confirmed HER2-positive metastatic breast cancer previously treated with more than 2 lines of a HER2-targeted therapy, and with a stable brain metastasis, they were enrolled. And neratinib and capecitabine versus LabCap. As we know, the dosages, they were given a 21-day cycle, and then until PD or progression. The primary endpoint was PFS, and the study was positive. There's either endpoint statistically significant, that is less than 0.01. Secondary endpoint was PFS, overall response rate, and intervention for CNS metastasis. Next. Next slide. So we can see that in the PFS median was 8.8 with neratinib and capecitabine versus 6.6 with the lab cap. And the overall survival is 24 and versus lab cap it's 22. It's almost similar. Next slide. So the CNS specific outcomes in patient with CNS metastasis at baseline. So lab cap and neratinib, as we can see that the median CNS PFS was 12 months. With the CNS PFS in the lab cap, it was 8.3. Next slide. Then margetuximab, it's a engineered and we can say antibody which alters the FC receptor and activate the immune response. So margetuximab has the same specificity, affinity to HER2 as trastuzumab with similar ability to disrupt the signaling. But via FC engineering with intent to activate immune response, margetuximab has altered the FC receptor activity. And with trastuzumab so we can see that with increased CD16 affinity, it enhances the innate immunity and more potent ADCC stimulation. And with decreased CD32B affinity, it enhances the adaptive immunity and increase the immune activation.
So I request you to conclude your session in 2 minutes. Thank you.
HER2 specific lymphocyte proliferation increase with the use of this margetuximab. Next slide. So it's a SOPHIA trial in which margetuximab with chemotherapy versus trastuzumab with chemotherapy in previously treated HER2 positive patients. Again, it's an open label phase 3 trial of margetuximab with chemotherapy versus trastuzumab. And next slide. So new drugs for the finish, it's a pyrotinib with capecitabine HER2 positive. So it improves overall survival and CBR. Primary toxicity is diarrhea, increase in the palmoplantar dysesthesias, Hanford syndrome, mucositis. Next, I think that's the last slide. Then is a TULIP. This is a trial of trastuzumab ducarmazine versus physician choice of chemotherapy for patients with previously treated HER2 positive metastatic breast cancer. So in this, patients with locally advanced or metastatic breast cancer, they were randomized to receive trastuzumab ducarmazine versus physician choice of chemotherapy till progression or unacceptable toxicity. And the primary endpoint was PFS by BSER and the secondary PFS or next slide. So cardiotoxicity, trastuzumab therapy, based therapy that is associated with decrease in the LVF and heart failure. All the causes TDM1, deruxtecan, margetuximab, lapatinib, they all carry warnings for cardiomyopathy, a decrease in the LVEF. But in the clinical trials, the rate for the heart failure or left ventricular ejection fraction declined. It was generally less than 2% with these agents. And ADCs and antibody drug conjugate margetuximab, they have not been studied in patients with left ventricular ejection fraction less than 50% at baseline. And with lapatinib, there is a risk for the QT prolongation. Next slide. So the cardiac safety of HER2 therapy in patients with reduced left ventricular function. So we can see that with, I think I'm short of the time. So next slide. Interstitial lung disease, that is with the taxane, with the anthracycline, with the TDM1, and with the mainly with the new drug trastuzumab deruxtecan. So the specific mechanism is unknown. It's a target independent uptake of the payload in immune cells, bystander effect. So the early diagnosis, we have to monitor the patient for the early signs. Next. So what are the strategies to manage ILD? That is to urge patient to immediately report in case of any respiratory symptoms, any worsening dyspnea, cough, any new pulmonary symptoms, to monitor the patient for early symptoms of interstitial lung disease by X-ray or by imaging, and to confirm it by the HRCT chest, pulmonology reference, bronchoscopy BAL if indicated, and ABG PFTs as per the protocol, and to manage if it's grade 1. Then we have to hold till the symptoms resolve for in case of a deruxtecan, And in case of TDM1, you need to discontinue. If it's grade 2 to 4, then permanently discontinue and treat with the steroid. Next.
Dr. Piyush, I request you to conclude.
Okay. Yeah, that's okay.
So thank you, Dr. Piyush, for such an extensive review of HER2 positive breast cancer. And now we can proceed to the next session.
So for the next session, I would like to invite Dr. Mukesh Bansal, who is consultant medical oncology and hematology, IVY Hospital, Mohali, and he's going to deliver his talk on redefining the standard of care for postmenopausal HR positive, HER2 negative ABC. Over to you, sir.
Hello, are my slides visible? Hello.
Yeah, sir, it is visible, but it is in too short form. Like you are from your mobile. Are you showing from your mobile?
No, I am doing from my tab iPad actually. Can you share my slides actually?
Okay, sir, do we have a sir slide?
Yes, sir. Yes, sir. I'm sharing.
Okay.
Can you, sir, can you stop
Stop
sharing?
sharing.
Yeah, sure. So are my slides, now the slides are visible?
Yes, sir.
Okay.
You can go ahead.
Yeah, good evening, everyone. I would like to thank the organizers for giving me this opportunity. So the topic given to me is redefining the standard of care for postmenopausal hormone positive HER2 negative advanced breast cancer. Next slide. Next slide. So in this talk, we will be discussing a patient-based case study, and we will be discussing different points. What are the approach considerations? What are the goals of the treatment in this patient? What is the role of CDK4 inhibitors in advanced breast cancer patients? What are the currently approved CDK4/6 inhibitors? What are the latest NCCN ESMO guideline recommendations about postmenopausal hormone positive HER2 negative metastatic breast cancer patients? We will have a brief discussion about Mona Lisa 2 study outcomes. We will have a ribociclib comparison with other CDK4/6 inhibitors so that how we can choose between the different CDK4/6 inhibitors in our clinical practice. Next slide. So there is a patient profile. There is a 63-year-old woman who presented to her healthcare provider with a lump in her breast. So on examination and workup, she had a 2.1 centimeter right breast mass, 2 palpable axillary lymph nodes. USG and mammogram confirmed these physical findings. So she's a T2N1 disease on clinical examination. So by her healthcare provider, she was referred to a medical oncologist who did a core needle biopsy that showed it to be a hormone positive HER2 negative breast cancer. ISC score is, I think, wrongly written here 3+. It is HER2 negative. So on CT scan of the chest, abdomen, and pelvis, there were 2 liver lesions. MRI brain was negative. So she is a metastatic breast cancer patient, postmenopausal, who is hormone positive and HER2 negative. Next slide. So what are the treatment goals in this patient? So most important treatment goal, I think, will be to prolong the survival. Because in metastatic settings, we have very good agents now available, so we can, which can prolong the overall survival of the patient. Second will be, as it is a palliative setting, to restrict the treatment-related toxicities is also important. Symptomatic relief is very important for patients who think a survival and other things as a data only. The things matter to them is symptomatic relief first, and then the quality of life. Next slide. So what is the management algorithm for hormone positive, HER2 negative advanced breast cancer patients? So the first line therapy, the options to us are either to use aromatase inhibitors or tamoxifen alone, which are not preferred genes according to NCCN guidelines nowadays. So the NCCN now says the category 1 recommendations are the combination therapy, which can be either in the form of aromatase inhibitors plus CDK4/6 inhibitors or fulvestrant plus CDK4/6 inhibitors. So if we have used aromatase inhibitors or tamoxifen alone, then in the second line therapy, we have the option of fulvestrant combined with CDK4/6 inhibitors and reserving exemestane or everolimus for third line therapy or chemotherapy in some patients. So if we have used the combination therapy in the first line, which is the preferred recommendation nowadays in the form of aromatase inhibitors and CDK4/6 inhibitor, then in the second line we have the option of fulvestrant, and in the third line exemestane or everolimus. Next slide. So what are the international guideline recommendations? ESMO, ESCO, and NCCN, they all agree on one point, that hormonal therapy is the mainstay treatment for patients with hormone positive, HER2 negative, advanced or metastatic breast cancer patients. So nowadays, the role of chemotherapy in hormone positive metastatic patients is declining day by day, especially with the advent of newer agents. I will say CDK4/6 inhibitors and PIK3 inhibitors. So these drugs have really changed the treatment landscape for hormone positive metastatic breast cancer patients. So CDK4/6 inhibitors combined with aromatase inhibitors as the preferred first line hormone therapeutic option can confer 40% overall response rate and median progression free survival of about 2 years for hormone sensitive patients defined by ABC2 guidelines. Next slide. So what is the role of CDK4 inhibition in advanced breast cancer patients? CDK4 plays a key role in breast cancer tumorigenesis and cell proliferation. The levels of CDK are upregulated more than 8 times compared to the levels of CDK6 in breast cancer cell lines. So specifically inhibiting CDK4 more than CDK6 may confer a clinical benefit. The inhibition of CDK4 has been shown to block the ability of breast cancer cells to form tumors. Next slide. So what is the rationale of targeting CDK4/6 inhibitors in these kind of patients? So this is a diagram of the cell cycle showing different phases, G1, S, G2, and M phase. So what are the most important things in this diagram? The estrogens, the estradiol hormones, act as a growth promoters. They bind to the estrogen receptor, which via the downstream signaling pathways of PI3K, cyclin D, MET, ERK, and other molecules, leads to cell cycle progression and cancer progression, tumorigenesis. So the mitogenic pathways, including estrogen signaling, stimulate cyclin D production. Binding of cyclin D activates CDK4/6. So how these molecules act? So in normal conditions, the tumor suppressor retinoblastoma gene inhibits the E2F transcription factors, which are responsible for the cell cycle progression for the G1S checkpoint. But in when the estrogen stimulates these estrogen receptors and activates the downstream signaling pathways, then the cyclin D forms a complex with cyclin CDK4 and 6, which inhibits the retinoblastoma RB tumor suppressor gene and inhibits the E2F transcription factor so that it can activate the cell cycle, continue the cell cycle progression. So we have mainly the 3 targets in the cell cycle. Either we can inhibit the estrogen hormone, that we can do by aromatase inhibitors.
From your
Or we can inhibit the estrogen receptors by fulvestrant, which is a selective estrogen receptor downregulator, or we can target the downstream molecules. So in patients who progresses on endocrine therapy or have endocrine resistance, there are various pathways by which endocrine resistance happens. It can be due to overactivation or amplification of the estrogen receptor, or it can be due to the overactivation of the downstream pathways. So the rationale is to combine both the things. First, we inhibit the growth activation by estrogen or receptor, and also take care of the downstream signaling pathways to prevent the endocrine resistance. So selectively inhibiting CDK4/6 causes cell cycle arrest in G1 phase, resulting in reduced cell viability and tumor shrinking. Next slide. So how to choose a CDK4 inhibitor, CDK4/6 inhibitor? Stage of the breast cancer is important because recently a abemaciclib has been FDA approved for the adjuvant settings also, while palbociclib and ribociclib are only approved in metastatic settings. Treatment history of the patient: if we have if the patient has already progressed on a CDK4/6, we can't use it again. Relapsation rate of cancer, type of patient, the side effect profile, because all the CDK4/6 inhibitors have different side effect profiles. What is the treatment team preference, either ongoing therapy or 3-week on and 1 week off, and other financial issues can also be there. Next slide. So CDK4/6 inhibitors in advanced breast cancer. Investigation into CDK4/6 inhibition in combination with endocrine therapy has significantly altered the treatment landscape. In the first-line setting, the addition of CDK4/6 have significantly improved progression-free survival, overall response rate, and clinical benefit ratio versus endocrine therapy alone. Next slide. So these are the clinical trials on the approved CDK4/6 inhibitors. We have PALOMA-2 trial, which was a first-line setting trial. In this trial, letrozole was combined with palbociclib. 666 patients were there. It showed a progression-free survival of 27.6 months versus 14.5 with letrozole alone. We have Mona Lisa 2 trial, in which letrozole was combined with ribociclib. Again, 668 patients, PFS benefit of 25 versus 16 months. Monarch 3 trial, letrozole or anastrozole plus abemaciclib, PFS 28 versus 14 months. Mona Lisa 3 trial, it included patients of both first and second line, fulvestrant with ribociclib, 33 versus 19 months. And Mona Lisa 7, first line trial with tamoxifen, letrozole, or anastrozole. All kinds of endocrine therapy options were there with ribociclib, again showed a PFS benefit of 23 versus 13 months. So all the approved CDK4/6 inhibitors in first and second line settings have shown a PFS benefit, while the maximum number of trials have shown benefit with ribociclib, Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. Next slide. So do all CDK4/6 inhibitors result in improvement in overall survival? Like we have seen that all the CDK4/6 inhibitors improves progression-free survival. But the better marker in any cancer patient is overall survival. So that is considered as a gold standard in drug approvals. Next slide. So ribociclib is the only CDK4/6 inhibitor to demonstrate significant overall survival in 3 trials. Abemaciclib has also shown significant overall survival benefit in Monarch 2 trial, but that included patients of both first and second line therapy, where abemaciclib was given with fulvestrant. While palbociclib is yet to show any OS benefit, while PFS benefit is there in different PALOMA 2 and PALOMA 3 trials. Ribociclib in Mona Lisa 2, 3, and 7 in first line and in both first and second line trials has shown significant overall survival benefits with different endocrine therapy partners. Next slide. So Mona Lisa 2 is the largest first-line study in postmenopausal women. It is a phase 3 trial investigating ribociclib plus letrozole in first-line setting in postmenopausal hormone-positive, HER2-negative advanced breast cancer patients. Statistically significant PFS benefit was reported in this trial, 25 versus 16 months. Updated report represents exploratory analysis and showing overall survival benefit also in the final OS analysis. Next slide. So in this trial, Mona Lisa 2, postmenopausal women with hormone positive HER2 negative were taken. No prior therapy for advanced disease was allowed. Prior neoadjuvant endocrine therapy, including tamoxifen, was allowed. Total number of 668 patients were there. They were randomized 1:1. Equal arms. In one arm, ribociclib 600 mg per day, 3 week on, 1 week off, with letrozole 2.5 was given, and in the other, letrozole alone with placebo was given. So the primary endpoint was PFS according to CIST 1.1 criteria, and the secondary endpoints were overall survival, ORR, and quality of life. Next slide. So ribociclib achieved longest reported overall survival benefit. It resulted in about 12.5 months. That translates to nearly a year of overall survival benefit. There was 24% relative reduction in the risk of death. So overall survival was 63.9 months versus 51.4 months. Next slide. So it showed consistent overall survival benefit over time. At 4 years, the OS benefit was 5.7%, at 5 years, 8.4%, and at 6 years, 12.2%. Next slide. So in the subgroup analysis, the overall survival benefit was consistent. If we compare with number of metastatic sites, less than 3 metastatic, more than 3, the hazard ratio were 0.77 and 0.70, showing significant benefit in both groups, with liver involvement, without liver involvement, with lung and liver involvement, with and without, with bone lesion only mets, and in de novo patients. So in all the subgroups, the ribociclib plus letrozole combination showed a significant overall survival benefit. Next slide. Ribociclib delayed time to first chemotherapy by almost 1 year. So the median time to chemotherapy in the placebo arm was 38.9 months, about 3 years. In the ribociclib plus letrozole arm, it was 50.6 months, which is more than 4 years. So we can give the patient more than a year of chemotherapy-free lifespan. Another important aspect is that CDK4/6 inhibitors or ribociclib in particular improves PFS and overall survival. But what about if a patient comes with widely metastatic disease where we desire a rapid reduction in tumor size, a rapid reduction in disease volume and load? So how the CDK4/6 inhibitors compare in these kind of patients? So in this Mona Lisa 2 trial, they divided all the patients who responded into 4 groups. Group 1 were the patients who had more than 60% reduction in tumor size at 8 weeks. Group 2 were 35 to 60%. Group 3 were 14 to 35%, and group 4 were patients who had less than 14% reduction in tumor size. So in the ribociclib plus letrozole group, 32% patients achieved more than 60% reduction at 8 weeks compared to 17% patients in the letrozole plus placebo group. So showing that rapidity of response is also there in this group. Next slide. So a large number of patients remained on treatment with ribociclib plus letrozole in the Mona Lisa 2 trial. 30 patients out of 334 are still ongoing as of June 2021 on the treatment arm, while 17 patients are still ongoing on placebo plus letrozole arm. Next slide. So what about the adverse effect profile? Because these agents are little more toxic than the simple aromatase inhibitors, be it anastrozole or letrozole. So we have to carefully manage these patients. The majority of adverse events were, however, predictable, manageable, and reversible. The most common side effect is neutropenia, which is in many patients who have grade 1, grade 2, but in about 52%, in about half the patients, grade 3 neutropenia was also observed. In 10% patients, it was a grade 4 neutropenia, but luckily, febrile neutropenia was observed in less than 1% of patients in this trial. So the other side effects can be abnormal LFT elevation, liver function tests can be deranged, but most of these patients had an asymptomatic LFT derangement. Symptomatic disease was not there. Vomiting, nausea, fatigue can be there. Diarrhea can be seen in 38% of patients. Next slide. Next slide. Yeah. So Mona Lisa 2 trial shows us that ribociclib is a well-tolerated with highest level of CDK4/6 inhibition. So if we compare CDK4 versus CDK6 inhibition ratio, it is about 8x in ribociclib, 6x in abemaciclib, and equal inhibition with palbociclib. So the major safety concern with ribociclib, the dreaded safety concern, I will say, is QT prolongation. But if we carefully select the patient, like in this trial, all the patients who had corrected QT interval more than 0.45 seconds were excluded from the study. And then ECG monitoring was done regular to check the QT prolongation. Then we can.
So my apologies. 3 minutes left to conclude your presentation.
Yeah, I'm about to conclude. So we can manage this side effect also. In abemaciclib, we say the major safety concern is diarrhea, which was seen in 86% of the patients. Many patients had mild grade 1, grade 2 diarrhea episode, but yes, some patients do require drug dose interruption and permanent discontinuation due to diarrhea. In palbociclib, there is risk of hematological toxicity like neutropenia. So ribociclib exhibits manageable safety and tolerability profile with more selectivity for CDK4 versus 6 and more drug available to penetrate and act on tumor cells. Next slide. So is ribociclib a rational first-line choice? Combined with endocrine therapy, the only first-line treatment with longer OS benefit, a preferred treatment option for hormone 2 HER2 negative, we can say it can be considered, and has shown consistent OS benefit regardless of endocrine therapy partner, line of therapy, or menopausal status. Next slide. So the only CDK4/6 inhibitor proven to help patients live longer. It results in longest reported median overall survival, longer delay in time to chemotherapy, about 1 year compared to the other arm, improvement and preservation of quality of life because side effect profile is manageable, and established safety profile. Next slide. Thank you.
Thank you, Dr. Mukesh, for such an elaborate presentation. So if anybody has a question, we have just 2 minutes. We can take some questions. And I think I have one question. How do you decide between various CDK4/6 inhibitors? What are the factors which you look for?
Yeah, like if we see overall survival benefit, it is most with the ribociclib in most of the trials. And second is the safe comorbidity profile of the patient. Obviously, if a patient has any cardiac issue, we will not bother him with the ribociclib. We can go with the palbociclib or the other one. And if the patient does not have any cardiac issues, does not have any major comorbidities, we can go ahead with ribociclib. I think we can prefer it. Yeah, at least I am doing it in my clinical practice.
So do you think what are the cardiac issues? I mean, you know, whether it's a cardiomyopathy or, a patient who has some blocks, AV blocks, what are the cardiac factors which, you would see before prescribing Crixana?
Yeah, before prescribing Crixana, as the trials say, we will have to very strictly check the corrected QT interval. Or if the patient is on any QT prolongation type of drugs, the stimulator drugs, if the patient is on any of these drugs, then we will definitely not start the Crixana.
Okay, thank you. Anybody else having any question?
Thank you, sir. So we move on to next speaker, Dr. Ullas Batra, who is Senior Consultant Medical Oncology, Chief of Thoracic Medical Services, Rajiv Gandhi Cancer Care Institute and Research Center, Delhi. And he's going to talk on patients' reported outcomes in patients with PIK3CA mutated HR plus HR2 negative advanced breast cancer from Solar. Over to you, sir.
So good evening and welcome.
Thank you, Priyanshu. It's good to see you after 3 or 4 years. The only thing that has changed is a little more fat on your face and a little more degrees at the end of your name. The rest of the things are almost the same.
I think so. I'm copying you, sir.
Okay, don't tell me. I'm warning you. Don't do that. Okay, so I had been asked to talk about the patient-reported outcomes, but I think I've just taken the liberty to change the topic because I want to speak about the entire spectrum of HR positive and HER2 negative metastatic breast cancer, especially about what happens after the CDK4/6 inhibitors were over. So when I first read the topic, my first reaction actually over there was this. This exactly is a hormonal positive CA breast, and this is tamoxifen with them. This is AIs with the HR positive metastatic CA breast, and then you have a CDK4/6 inhibitors, and then this girl wants more. So you already have tamoxifen, you have AIs, you have CDK4, and now you want alpelisib also. My subsequent reactions when I looked at this topic basically was the last statement over here, that only 30% or 40% of the patients remain progression-free on treatment 2.2 years after initiating the treatment and a CDK4/6 inhibitor. So yes, we have made progress in hormone-positive CA breast, but a lot needs to be done. So definitely you have got a point. Definitely there's a space for newer agents in a hormone-positive CA breast. My second subsequent reaction was that the honeymoon is over. So in short, the SOLAR trial actually starts after the honeymoon with the first line ET, that is the Mona Lisa or the Monarch or the Paloma trial actually ends. So let's talk about the PIK3CA pathway in breast cancer. And I'll start with my 6 basic questions about who, what, where, why, and how. So let's start with what exactly is a PI3K pathway in HR positive breast cancer. So if there are any residents listening over there, basically PI3K mTOR pathways frequently altered in metastatic CA breast. It basically leads, because of the PIK3CA mutation, it leads to hyperactivation of PI3K pathway. Is that important or not? It is very important. It is actually 40% of the patients actually have a PIK3CA mutation, which will lead to a hyperactivation of the path and following more growth and anti-angiogenesis inhibited. So that is why it is very, very important. Now, what is the prognostic role of PIK3CA mutations? Basically, people who had PIK3CA mutation did worse than what people who did not have. It was 19.36 versus 23.5 months. So definitely it is a very, very, very clinically important mutation that is there. So now 40% of people get a PIK3CA mutation. The answer is simple. Just block it. It's very, very easy. We all have smartphones with us. You don't like a number, you block it. Unfortunately, it has never been a smooth ride all over. What we imagine our plan to be PIK3CA is like you want to go in a straight line. But in reality, your plan is compounded by multiple crests and troughs. So I'll talk about the downs first, and then I'll go about the ups later. So PIK3CA inhibition is not something, the PI3K inhibition is not something which has come overnight. Novartis has got a drug right now, but that doesn't mean that this drug was, or the strategies to prevent PIK3CA was not before. It was all there. You initially had a pan PI3K inhibitors, then you had a dual pan PI3K mTOR inhibitors, and now you have an isoform specific inhibitors. So finally, initially you were trying to block the entire PI3K, then you started blocking the dual pan PI3K mTOR, and now you basically block the isoform specific PI3K. Now this was the first agent, that was the buparlisib, and this buparlisib plus fulvestrant was compared against placebo plus persistent as the BELLE-2 trial, and this trial did not show any advantage. So the first generation failed, the second generation failed, and the third generation is basically alpelisib. So what is the solution? Let's be more specific. So from a class 1 generation of pan PI3K inhibitor, you go to second generation, and now you go to more isoform specific. So what exactly do you mean by isoform specific? So we all know that PI3K includes the catalytic subunit. It includes the regulatory subunit. In the catalytic subunit, there are 4 isoforms. So there are 2 isoforms. This is a catalytic subunit. This is a regulatory one. In the catalytic subunit, you have 4 PI3K isoforms. Alpha-celeb is basically a specific inhibitor of a PI3K alpha isoform. So starting from the entire pan PI3K, you go down to dual. From the dual, you go on to a specific isoform, and this is the alpha isoform that basically alpha-celeb actually inhibits. So we are going and zooming in, like we are from MBBS to MD to DM, and there are certain people who do specialize in specific oncology. There are some stupid people who specialize in lung oncology from Rajiv Gandhi itself. So you're by and large, concentrating on one particular subunit only. So what did the SOLAR-1 trial did? SOLAR-1 trial basically compared people who had progressed on an endocrine therapy, who had received the AI, were randomized between alpelisib and fulvestrant versus fulvestrant and placebo. So the standard of care arm basically was fulvestrant, and alpelisib plus fulvestrant versus placebo was compared. They also compared PIK3CA mutant versus PIK3CA non-mutant. So first, you look out for the mutation. If you are mutant, you will get alpelisib fulvestrant versus placebo. Even if you're this thing, you will actually get the drug, and then you will see what exactly is happening around over there. Very importantly, 90% of the patients had mutational status identified from the archival tissue. In lung cancer, in other cancers, we always say we want the latest biopsy. But again, very important is you do not need the latest biopsy. 90% of the patients had mutational status from the archival tissue. The baseline characteristics were all very, very matched. Very important thing is that a lot of people had endocrine resistance, which was primary, which was seen in 27 or 13% of patients, and a secondary resistance. So by and large, both the groups had basically received were basically balanced. Prior CDK4/6 inhibitor treatment was there only in 6% in both the arms. So this is a point which is worth noticing over here. And this is the results which basically show, and look at the separation of the graphs. I always tell my residents, that look at the separation of the graph. The graph actually are separating very, very early. Within the first 1 to 2 months, you actually find out that the people who have got an alpelisib plus fulvestrant are actually doing well. The median PFS was doubled 11 versus 5.7 months. The median PFS by the centrally assessed cohort and the locally assessed cohort was by and large the same. It had a high response rate. Also, a lot of people will tell, we have an impending visceral crisis. So shall we give this or shall we give chemotherapy? The overall response rate, in fact, if you look over here, was 35.7%. With a single agent paclitaxel, you have around 40-45% in the second or third line. So you have a 35.7 versus 16.2. So that is also absolutely okay. Now, does this drug work only in PIK3CA mutant? So as a proof of concept, PFS in the PIK3CA non-mutant also was taken, and there was no difference in the cohort over there. So this drug is a very specific PIK3CA alpha isoform inhibitor and works basically in those. Any subgroup which did not benefit? No. Every subgroup basically benefited, whether you had lung mets, liver mets, bone mets, prior chemotherapy, primary resistance, secondary resistance, type of PIK3 mutation, whether the mutation was there by solid tissue or whether it was there by liquid biopsy. Every subgroup actually benefited from this treatment. Now, locally assessed PFS by tissue or plasma. A liquid biopsy is very, very famous in lung cancer and other cancers. So should we go ahead and do a liquid biopsy? Should we go ahead and do a tissue biopsy? It does not make a difference. Whether you have a liquid biopsy or you have a tissue biopsy, the results are by and large the same. Your PFS is 11 and 10.9. So there is no difference. If you have a PIK3CA mutation, either archival tissue or latest tissue, whether on solid biopsy or on liquid biopsy, it does not make a difference. Your alpelisib plus fulvestrant is really going to act. This is just to again say that the majority of the sample used for PIK3CA screening in SOLAR-1 were from the primary tumors. They were not from the metastatic site. So initial biopsy report, absolutely no hazard whatsoever. So what changed in year 2020? COVID came. this is what everybody knows. What Novartis does not want to tell us is a lot with a capital T change in the year 2020, because in the year 2020, this is what Novartis never wants to tell. The OS data of this trial was basically presented. The median OS was prolonged by approximately 7.9 months. However, because the OS analysis in this cohort did not cross the pre-specified O'Brien-Fleming efficacy boundary, they wanted one-sided P to be less than 0.0161, which did not cross. So numerical advantage of 8 months, but the statistical significance was not achieved. However, the OS by the subgroups, the bad disease, look at the liver disease. If you had a patient with liver disease, this drug really works over here with a median overall survival of 37.2 versus 22.8. This is the difference, that if used in the right patient, then that this drug actually can work. The time to first chemotherapy, again, the chemotherapy, even if you're sitting in AIMS or Tata or Rajiv Gandhi or the way where Priyanshu is practicing, nobody wants chemotherapy. Everybody wants to delay the chemotherapy, and a median delay of 8.5 months was observed for till the time to chemotherapy in the alpelisib plus the fulvestrant arm. So the conclusions were, there was a numerical OS advantage, 7.9 months. It was not statistically significant. However, patients with liver and lung metastasis derived greater benefit from this drug rather than the other one, and obviously it delayed time to first chemotherapy. So that was the conclusion which was given by the ESMO 2020. However, if it's too good to be true, there is something wrong. So this is there is something definitely wrong. It is not an easy drug. Let's be very honest about it. You cannot give it to. It is not a gefitinib. It is not a tamoxifen. It is not a letrozole. It is not a imatinib. This drug requires careful selection of patients. And why I am saying this is because the grade 4 AEs were there in hyperglycemia and diarrhea to the tune of around 12% and 4%. 25% of patients actually discontinued alpelisib, 18% for hyperglycemia, 9% for rash. It was basically discontinued. So this is what, I told you initially, the honeymoon was over. And even if the honeymoon was not over, the shadi has its side effects over here. So let's get practical. We know the drug is toxic, but isn't a dose dense AC-Taxol toxic? Isn't bone marrow transplant toxic? Isn't some other chemotherapy toxic? Do we stop giving them? If there's a benefit, we select the right patient actually over there. So let's get practical about expectations. Let's see what exactly is going to come when we give PIK3CA. The first and the foremost thing which I ask my patient is about the history of diabetes. A lot of people will be diabetic, some of them will not be diabetics. A very important thing is to tell them that you will get diabetes. Your sugars will go high. Now, why will your sugar go high? Because the insulin signaling through the PI3K drives the glucose uptake into the cell. So what happens is, if you have a PI3K cell over here, the glucose transport cells move up to the surface to drive the glucose uptake. If this PI3K is blocked, the glucose transport receptor will stay inside the cell. It will never go to the surface. Obviously, your sugar will high. So your sugar will raise. You tell the patient that this is a side effect, your sugar will raise. You have to monitor your sugar in the first 1 or 2 weeks. I'll come to that. A very beautiful article which was published in Annals of Oncology by Hope Rugo. What this basically said was, see, this is basically to show that everybody learns on the job. Initially on the SOLAR-1 trial, the HbA1c inclusion criteria was 8.5. They had huge toxicity. What they did was they reduced the criteria to less than 6.5%, and then it changed over there. Again, there were rashes. They gave prophylactic antihistaminics. It came down. They told the patient diarrhea was there. It came down after that. And the best point is the initial occurrence of both the higher grade hyperglycemia and rash were observed within the first 2 weeks of the treatment. So you should tell the patient. I always call my patient initially on the first 7 days, then on the 15 days, and tell them, please monitor your sugar. I give them a prophylactic anti-allergic, and I do not give it to people who have an HbA1c of more than actually 6. If it is 6.5, I tell them to meet an endocrinologist and then take treatment. It is not only enough to ask them to meet an endocrinologist, because people will maybe use insulin to start with. In fact, it is very important to monitor their sugar. Start with metformin. Start with metformin 500 mg, then put it 500 mg BD. Then you increase the dose. Doesn't make a difference. Then you add an insulin sensitizer, that is a pioglitazone. doesn't make a difference, then you use insulin. So it's very, very important for us as medical oncologists to know what exactly basically we are dealing with. Start with metformin, add pioglitazone, then add insulin onto it, and the side effect will be easy. Lifestyle change is very, very important. Ask them to walk and be exercise. Take a good diet, not a Punjabi diet that we all are supposed to take. The second most important thing basically is the rash. Now, I always again tell my patient rashes will be there, and I do give them a prophylactic treatment prior to the onset of rash. Do not wait for the rash to occur. I actually give them fexofenadine 180 mg. My prescription will include fexofenadine, antidiarrheal measure, regular BP charting, regular sugar charting. And this was a trial basically which said only 25% in the patient who got a prophylactic antihistaminics developed a rash, as against 65% of people who did not get. So tell them the sugar will get high, tell them to monitor their BP, tell them about the diarrhea, tell them about the rash, give them prophylactic antiemetics, and things will be absolutely okay. This is something which is very, very important. This is what the patient-related outcome basically was there. And what they basically found out was that the QLQ C30, that is the quality of life quotient, C30, global health status quality of life, was not different between the alpelisib and the fulvestrant versus the placebo and the fulvestrant arm. And this is exactly what was in the SOLAR trial. So this actually came as a news to me. I mean, I was actually thinking the quality of life will become more worse with that. But no, it was not different between them. Alpelisib did not do this thing, because again, because of partially the side effect, because alpelisib prolonged the PFS, that is why it was able to counter the side effects. Now, I did show you alpelisib does in the SOLAR 1 trial, there were very few patients with CDK4 inhibitors. So what about the CDK4/6 inhibitors? That's somebody's got a Mona Lisa regimen. Will alpelisib work? So there's a trial which was published in SABC 2021, and this was the BYLieve trial. The first cohort over there is patients of 112 patients who have got CDK4/6 inhibitors plus AI as an immediate prior treatment. And again, here the PFS basically was 7.3 months. The 18-month PFS was 22%, almost similar to what we got in the SOLAR trial. The median OS of around 26.4 months. So definitely this drug acts even after you have given alpelisib, ribociclib or palbociclib. So to conclude, I would like to conclude basically by saying, I showed you a photograph of a lady who was greedy, I would say. So I would actually say, stay hungry, stay foolish. Greed, for the lack of a better word, actually is good. And the stay hungry and stay foolish is for new drugs, for better overall survival. Greed is good for new drugs for a better overall survival. And with this, thank you. Thank you, Priyanshu, for the invite. It was lovely coming and meeting you after a long time. Thank you.
Thank you, sir, for such a lucid presentation. Sir, I have one or two questions, if you may permit.
So how times have turned, Priyanshu? 4 years back, I was the one asking questions to you, and now you are the one asking questions to me. Venkat also is smiling over there. Hi, Venkat.
So one is that when you were starting on a CDK4/6, do you think of getting a PIK3 testing at that very moment itself?
No.
Number one. And the second is, if we have a bone-only metastasis and the archival tissue is not available, do you go for a liquid biopsy?
So I'll answer the first question first. I don't test for a PIK3CA mutation upfront because it doesn't really solve a purpose. I mean, I will not change my treatment. So I do not test at that time, maybe later on. Liquid biopsy, Priyanshu, is expensive. The only reason over there is if you do a PCR test for a tissue biopsy, it will cost 11,000 rupees. There are things which are there. And liquid biopsy, again, the sensitivity problem with liquid biopsy, if it is positive, it is positive. But the sensitivity of liquid biopsy is generally 80%. So I would probably get, so even if I have a bone mets, I will try to get the initial biopsy, which is usually available. There should not be an issue with that.
Okay. Okay, so thank you. Anybody having any more questions?
I do not have question, but I have a comment.
Yes, Venkat, go on.
So, IPL is going on. So when someone asks what is the difference, although both are very good batsmen, Dravid and Dhoni, when someone asks what is the difference between the batting style, so there are some emotions attached to the Dhoni batting, and people they have their emotions arise. So it is same with Dr. Ullas Batra's talk and any other senior talk. So That is the
So you're
only
calling me
common.
Dravid or you're calling me Dhoni? You think
Dhoni,
that I
sir,
should,
absolutely.
you think I have already retired or I should retire next 1 year? Tell me
Yes,
that.
sir, Dhoni. No doubt,
So
Dhoni.
you
Sir.
think I should retire next year? Okay, Venkat, I'll take it over there.
Thank you, sir.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you. Thank you, sir. And next, I will invite Dr. Venkat Pradeep Babu, who is Senior Consultant Medical Oncology, Assam Cancer Care Foundation, Deshpur. And he's going to talk on adjuvant abemaciclib in high-risk early breast cancer. Over to you, sir.
Welcome, sir.
Thank you, Dr. Priyanshu, for this opportunity. So in continuation to my mentor's talk, Dr. Ullas Batra's talk, where we ended with a new hope to find the new drugs, better drugs and better overall survival. This is regarding a new indication of the old drug, abemaciclib, in a new setting, in the adjuvant setting. So I will try to show the results of this new drug in a newer indication. So this is about study called Monarchy. It is about inclusion of a new anti-adjuvant adjuvant drug, anti-hormonal drug, CDK4/6 inhibitor, in the adjuvant setting of early breast cancer. The high-risk early breast cancer, we know that very much risk of relapse. My slides are not moving. Yeah. So when we start the treatment in the adjuvant setting, the entire family is worried when the lady or the homemaker is diagnosed with cancer, and they will ask about the chances of cure. And when we see clinically it is early breast cancer, definitely there is a lot of hope in the air and in the OPD room, and there is a lot of discussion of about the hope that will be discussed between the physician and the patient and the family. And after a tedious diagnostic armamentarium and then undergoing chemotherapy, surgery, and sometimes adjuvant radiation when necessary, patient feels the treatment is over and I am cured. But they are not so worried about the hormonal therapy, which many of the physicians will stress that there is no much of the side effects for this hormonal therapy, and they are very happy to continue the hormonal therapy for 5 or 10 years, and they feel they are cured. But we know that majority of the high-risk early breast cancer, they ultimately have relapse. And after relapse, they are so disappointed with all this conversation happened early that the patient will get better. So they are utterly disappointed. So can we do something that can prevent this scenario or postpone this scenario or even prevent this scenario in some of the patients? This is about all this trial that is called Monarchy trial. Can we add better drugs in addition to the standard hormonal therapy to prevent relapse or in fact to prevent the metastasis or even the local recurrence? So this is a drug called abemaciclib. We all know is a CDK4/6 inhibitor, which is one of the potent CDK4/6 inhibitors of all the three, which can act in the brain also. Let us see the trial design graphically. So it is in the early breast cancer. It is a high-risk early breast cancer. Hormone positive and HER2 should be negative, and node should be positive. So what are the groups they have included in this study? If they have 4 positive axillary lymph nodes, they can directly be included in the study. If they have 1 to 3 positive axillary lymph nodes, they should have one more additional criteria to get included in this study. One of it being grade 3, a tumor size greater than 5 centimeters, or Ki-67 greater than 20%. This should be a centrally tested Ki-67 because Ki-67 is usually done by immunohistochemistry, which is subjective to each pathologist, and so it should be centrally tested. And other inclusion criteria in this is even men with breast cancer can also be included. Both pre and post-menopausal women have been included in this study. The previous chemotherapy is not a contraindication, or it is not required also. Anything, both with or without chemotherapy, can be included. And obviously, there should be no metastatic disease. When we see the number of patients enrolled in the study, nearly 5,637 patients with 1:1 randomization. So what are the stratification factors they want to look at? People who received chemotherapy versus who do not. menopausal status, pre versus postmenopausal status, and ethnicity by region. The two arms are abemaciclib in addition to the standard of care endocrine therapy at a dose of 150 milligrams twice daily and endocrine therapy. And the trial is to give 2 years of abemaciclib in addition to the standard endocrine therapy, which can be up to 5 years or 10 years. The primary objective is to look at whether there is any difference at 3 years in invasive disease-free survival. And secondary objective is to look at the distant metastasis, that is invasive distant metastasis-free survival in Ki-67 greater than 20%, and overall distant recurrence-free survival, the overall survival, which is obviously requires much longer time in the adjuvant setting. Safety, are there any new safety signals? What are the other pharmacokinetic parameters and patient-reported outcomes? We shall see all these criteria in little more detail. When we see the other key inclusion criteria, the patient must have undergone definitive surgery of the primary breast tumor within 16 months of randomization when included in the study. Other important inclusion criteria is the patient, if she or he has undergone chemotherapy or radiotherapy, the side effects should be minimal and they should be less than or equal to grade 1, which means almost they should be asymptomatic. Only then they are eligible to be included in the study. They should have excellent performance status of ECOG 0 or 1, and they should not be having any significant comorbidities, which means all organs should be functioning. There should be no end organ dysfunction, and they should be in a situation to take oral medication. What are the exclusion criteria? Inflammatory breast cancer, if it is diagnosed, it is out of the study. And any history of breast cancer, which is invasive breast cancer in either of the breast, 5 years before in last 5 years, they are excluded from the study. Pregnant women or pregnancy breast cancer, they are excluded, and breastfeeding, they are not included. And any prior exposure to CDK4/6 inhibitors should not be there. And they should also should not be receiving any other hormonal therapy. And history of syncope of cardiovascular etiology, ventricular arrhythmia, and sudden cardiac arrest, which means the cardiac status should be perfect, and there should be no history of venous thromboembolic event previously, even including in pregnancy. And if patient has received any experimental therapy in the last 30 days, they are excluded. That means they should not be in any other clinical trial before. So these are all the exclusion criteria. And we have seen that the primary objective, because it is adjuvant setting, assessing overall survival is not so easy. It will require quite a time. So the primary objective to see whether we can prevent the invasive disease-free, whether we can achieve the invasive disease-free survival significantly compared to the standard endocrine therapy. Other secondary objectives are, if IDFS is being prevented in high-risk patients of Ki-67 greater than 20%. Because Ki-67, we know, although it is not mentioned in many of the institutional reports which after the biopsy report, but in those with particularly hormone positive in early breast cancer in adjuvant setting, some of the tools which we use to assess whether we need to use the adjuvant therapy or not, Ki-67 is an integral part of that most of the tools. So here also Ki-67 is a must. And disease-free, relapse-free survival is the other secondary objective, overall survival. So patient-related outcomes, there are 4 factors they have looked at. That is FACT-B questionnaire and functional assessment of cancer therapy, endocrine symptoms, including thyroid symptoms, diabetes-related and other endocrine symptoms, functional assessment of chronic illness therapy, FACT-F questionnaire, which is really an important factor. And EuroQL, EQ5D5L. This is the questionnaire they have used to assess the quality of life parameter in the patients who are receiving abemaciclib. Obviously, safety signals were assessed. So in ESMO 2020, an interim analysis was presented. And when we see the distribution of patients, they are almost equally distributed, 2,800 in each group, abema versus endocrine therapy. This invasive disease-free survival, when done at the interim analysis, this is a planned interim analysis, which is done at 15 months. So at 15 months, it was seen that nearly 12% of patients, they have completed the therapy. because these patients are being recruited over a span of time. At 15 months, which is the planned interim analysis period, only 12% of patients have completed the 2 years of Habermas sleep therapy. But even with the 12%, they have seen that the difference of 3.5% in IDFS rates in those population who have completed the therapy. When we see the absolute numbers, it is 92.2% IDFS in Abema group versus 88% in endocrine therapy group. In the same way, the second one of the important secondary objective is DRFS, that is distant metastasis. 28.3 reduction in DRFS was seen with Abema sleep. When we see the absolute values, 93.6 versus 90.3, which is 3.3% absolute difference at 2 years. So with at this point, they have mentioned that it is the first CDK4/6 inhibitor to show significant improvement in IDFS when combined with endocrine therapy. And at this point of 15 months, it has shown some hope that maybe adding Abema sleep will have definitive benefit. So the next analysis was done at 19.1 months, which is the primary outcome analysis, primarily to see the IDFS. And at this point of time, it was seen that nearly 25% of patients who were enrolled have completed 2 months of 2 years of Abema sleep therapy, and there were 390 events by then. And when we see the 25% reduction with HR of 0.747, which means nearly 26% of events were reduced in patients who are using Abema sleep. In the same way, the 28.3 reduction in the distant metastasis. This is at 19 months. Now in 2021, we have.
So my apologies. My apologies, sir. You are left with 3 minutes to conclude your presentation.
All right. So in 2021, we have furthermore analysis at 27 months, where nearly 87% of patients have completed 2 years of therapy, and 17% they were dropouts. So they have one of the secondary objectives to see whether there is IDFS benefit in Ki67 high greater than 20%. And it was seen that not only in Ki67 high, but in Ki67 low, there is definitive benefit of using Abema sleep. When we see the curve here, sorry for the small figure, there are 4 curves here. So Ki67 low with endocrine therapy, you can see, and with adding up Abema sleep, there is definitive benefit. The curves are really separating from early onwards. And here, in patients who are at high risk, greater than 20% and Ki67 high, Abema sleep is far much higher than those who are using endocrine therapy. They are the people we know at a very high risk of recurrence. And coming to the safety signal, are we very, very happy with the Abema sleep? A little bit of doubtful. Why? Because in the first 3 months, it is definitely a test for the patient. And obviously, physician should take care to do a very good counseling. Then after 3 months, patient will be very much comfortable with Abema sleep. When we see the side effects here, greater than grade 1 adverse events, they are 97%, and grade 3 adverse events nearly occurs in half of the patient population when compared to the 14% in only endocrine therapy. And one of the significant side effects is diarrhea, very important side effect that need to be managed. And most of the diarrheal events occur in the first 3 months. And second significant is neutropenia. Majority of this neutropenia will not result in neutropenic fever. And other important side effect that will affect the quality of life is fatigue and obviously nausea. So some of the patient might need antiemetics also, although we are not giving chemotherapy. 17% of patients, they have discontinued Abema sleep due to various side effects, and majority of the discontinuation occurs in the first 3 months. So first 3 months, counseling, talking, assessing patients, looking for the side effects, also including this venous thromboembolism, which is significant side effects. They have seen that it occurs in the first 3 months. So clinical examination, continuous follow-up, counseling, all these are very important in the first 3 months. Diarrhea, venous thromboembolism. Venous thromboembolism occurs at 2.5% of patients. Pulmonary thromboembolism occurs in 1% of patients. And in patients receiving only endocrine therapy, it is 0.1%. So we need to assess the symptoms in shortness of breath, dyspnea, etc. ILD is reported in 2.9% of patients. So first 3 months of Abema sleep needs a lot of support. After 3 months, patient will be very comfortable in continuing up to 2 years. So counseling is important. So this is the repetition of slide where there is 7% difference in case in terms of benefit of abemaciclib in case 67 high. So to conclude, abemaciclib plus endocrine therapy, they significantly reduce the risk of developing invasive disease at 2 years and at 27 months of analysis also, particularly in those with high risk disease of early breast cancer. At least this will prevent many of the disease-free events in these patients, and we can prevent the recurrence and we can extend the happy days further. So with this, these are the countries in which monarchy trial was included. However, India is not a part of this, and Americas, European, and Asia Pacific. And with this, I conclude my talk. Thank you so much.
Thank you, sir, for such a wonderful presentation. I don't think so we have much time for question, but just from my side, do you think this is practice changing? Would you include this therapy in your guidelines, provided the patient has enough money? Probably some subset which you would select for using, apart from the criteria which you have mentioned in the trial.
Yeah, so Dr. Priyanshu, we know that particularly in those with more than 4 nodes positive and with case 20%, if the patient has no financial constraints, definitely we should give the option, and we should leave the option for patient, because we now have FDA approval also for that indication.
So would you probably try it more in young patient, or would age be a criteria for selection?
Obviously, you will be more comfortable in giving younger patient, because older patients with a lot of diarrhea, they may not be comfortable, and the side effects almost resemble chemotherapy in
the first 3 months. Yeah. Okay. Thank you, sir. Thank you, sir. Thank you so much. We now proceed to the next session.
Thank you. Yeah. So next, I would like to invite Dr. Navdeep Singh, Consultant Medical Oncology, Cancer Centers of America, Ludhiana, and he's going to deliver his talk on capmatinib, unlocking the unmet need in METX14 mutated non-small cell lung cancer. Over to you, sir.
Welcome,
Am I slide visible? Hi, thank you, Priyanshu, for this opportunity. Am I slide visible to you?
Yes, sir.
Yes.
Full screen, sir.
I'll be discussing about capmatinib. As we know, the treatment is quite evolving in the lung cancer, especially in the late stages. So, we'll discuss about this new drug capmatinib, which target basically MET exon 14 skipping mutation. So, what is c-MET? Basically, it's a hepatocyte growth factor receptor and is a tyrosine kinase receptor. So, in these patient can have exon 14 skipping mutation, then they can have this MET gene copy number gain or amplification, and the other thing with that patient can have these MET protein overexpression. So if we talk about the MET mutation in the non-small cell lung cancer, they are present around in 3 to 4% of non-small cell adeno-CA, and the around 1 to 2% in other non-small cell subsets. And these are mutually exclusive to other molecular drivers, including EGFR or alkyl translocation. So, especially they are detected in the patients more in the early stages of the diagnosis, elderly age, and the patients are non-smokers. So, if we see, there was the association of this MET mutation. It is associated with the worst survival outcome as compared to the presence in the patient in which the treatment is according to the MET mutation. The presence of MET mutation is basically associated with the worst survival. So there was a study in which the patients which are having MET mutation positive, they were treated with the immunotherapy. And as you see, you can see the large number of patients were adeno-CA, and there is quite a good number of PD-L1 scoring. Still, the patient, they responded poorly to this immunotherapy, with the most of the patient having progression of the disease. And the overall response rate was around 17%, a PFS of only 1.9 months, and the OS was around 18.2 months. So also, there are many case reports individually done, which showed that these patients who are having MET exon 14 mutation, they respond poorly to immunotherapy. So when there was a study in which 148 patients, in which it was seen if we inhibit this MET mutation with a specific target, the overall survival increased. So in the overall survival increased up to 24.6 months compared to the 8.1 month in the patients in which we didn't inhibit the MET mutation. So MET TKI basically used in this study was crizotinib, clisdatinib, and capmatinib. So we'll discuss about a capmatinib, which is a more selective MET inhibitor. So it's an oral ATP competitive, highly potent, selective and reversible inhibitor MET kinase. It's around having sensitivity of more than 10,000 fold and crosses the blood-brain barrier, showing in the preliminary blood-brain activity. So it has a potent blockade of MET activation in cell-based functional and biochemical assays as well as in vivo models. So compared to the other the MET inhibitors, the maximal inhibitor concentration of capmatinib is better than all. It's around half maximal inhibitor concentration around 0.6. So this study was basically a phase 2 study, which was done with the drug capmatinib. So in this trial, the patients, the baseline patient population which was taken was having age more than 18 years, any histology, and they should be wild type for the other mutations like EGFR and calcium negative, and they should have MET dysregulation, and which includes also the MET exon 14 skipping mutation having a good PS. So there were multiple cohorts, and these cohorts I will discuss in the next slide. They were put on the treatment regime with the capmatinib 400 mg twice a day. So what were these cohorts? So there were cohorts in which the patients have received some previous line of treatment, and there were cohorts in which there was no previous treatment. So in which the patient have some received some previous line of treatment. These were there was a cohort in which only there was a MET amplification with the gene copy number alteration more than 10. And then the second cohort 1B, only MET application with the gene copy number alteration of 6 to 9. And the other cohort was MET application with the gene copy number of 4 or 5. The cohort third was it was MET application with a gene copy number alteration less than 4. And the cohort 4 was patients were having any GCM and with the MET exon 14 skipping mutation. So these were the baseline cohort. With these patients received for 1 or 2 lines of therapy. And if the patient who didn't have received any previous treatment, there were cohorts 5A with the MET amplification and a gene copy number alteration more than 10. And the other was MET exon 14 skipping mutation, any GCM. These two cohorts, 6 and 7, these were the extensile cohorts. These were added afterwards. And this still most of the work on these cohorts is going on. So what were the objectives of this study? The primary objective was to demonstrate the anti-tumor activity of capmatinib. So the overall response rate was also assessed by the investigator, and there was also one blinded independent review committee that also assessed the results by cohort. And the key secondary objectives were evaluate the duration of response. The other secondary objectives were the anti-tumor efficacy, evaluate survival, evaluate the safety profile of capmatinib. Coming on the baseline characteristic, we will discuss 2 cohorts. Firstly, the pre-treated cohort 4 and a treatment name cohort 5B, both having exon MET mutation positive. So you can see most of the patients were having the elderly age group with a median age of 71. Most of the patients, they are also non-smoker. Most common histology was adeno-CA. And there were also patients that were having some baseline metastatic disease in the brain. So again, the concurrent MET application was present, and again this was divided into on the basis of the gene copy number amplifications or alterations. So if you see the cohort was a pre-treated cohort, and the patients have received firstly the platinum-based chemotherapies and also the immunotherapy. And the treatment naive patient, they didn't receive any treatment. So if you see the overall response rate, so you can see even with the blinded independent review committee and by the investigator, the overall response rate was coming around 40.6% and a 43.5%, almost similar. And again, similarly, the disease control rate was around 78% by both the investigators. But if you see the treatment naive patients, they responded more beautifully than the patients which were previously treated, and the overall response rates was around to the tune of 60 to 67%. And again, the disease control rates were much better the patients who have received previous any lines of therapy. So if you see tumor shrinkage, you can see this in the waterfall plot. The tumor shrinkage, the patient which were having treatment naive, it was quite good. And also, but the pre-treated patient, they also responded beautifully, and that there was a good number of tumor that shrink. So, and if you see duration of response in the patients who were previously pre-treated with any line of therapy, again, the duration of response was around 9.7 months. And in the patients who were treatment naive, the duration of response was around 12.6 months. So, and if you see the progression-free survival in that patients who had previously treated, and in the PFS was less. The PFS was around 5.42 months when the previously treated patient, and it was 12.4 months in the patient which were having didn't receive any treatment. And these PFS values, if you see this was by the blinded independent review committee. Again, the investigator said the same PFS reported by the investigator also around 4.8 months for the previously treated patient and 11.9 months for the treatment naive patient. If you see against the activity against the brain mets, so there were around 13 patients. So 4 patients had a complete resolution of brain lesions, and the patients who three patients, one patient had a complete resolution of 3 lesions, and the one patient had a complete resolution of the 2 lesions, and there was almost the other lesions were almost stable. So the intracranial responses were very fast, and all had a first evaluation. All patients had a response in the intracranial disease. So if you see about the tumor shrinkage, when we talk about the other MET mutations, whatever that the mutation is, and if there is also a co-occurrence of the MET implication, then again the cohorts they responded well to this drug capmatinib, and there was again a durable and a sustained response with this drug capmatinib. So after some time, to study the more of efficacy of this drug, they added 2 more cohorts. These cohorts were expansion cohorts 6, and then again a new cohort which was treatment naive. That was expansion cohort 7 that was added. So if you see the result in this expansion cohort, the expansion cohort was again a treatment naive patient with the exon 14 skipping mutation. So again, the results were same as compared to the previous cohort. There was a overall response rate of 65%, and the disease control rate was around 100%. So if you see the patients, the other cohorts in which there was some previous line of therapies was given. So again, in these patients, even in the expansile cohorts and in the previous, the other cohorts which were earlier used and post multiple 1 or 2 lines therapy, the response rate was around to the tune of 40 to 50%, and the disease control rate was around 90%. So if you see the responses with this drug were rapid, and the responses occur within the starting the 2 months of the treatment, and the median duration of response was around 12.6 months in the first line, 8.4 months in the second line, and 9.7 months the second or the third line. The PFS in the first line was around 12.3 months, 6.9 months in the second line, and it was 5.4 months in the second or the third line. So basically, the response was seen in all the cohorts. And if you talk about the survival benefit, so the survival data is only available for cohorts 5B and 4. There is a good survival benefit, and there was a median OS of around 20.8 months in the cohort 5B, which is a treatment naive patient, and the cohort 4, which was a patient who are previously treated with any lines of therapy, the OS is around 13.6 months. So the coming on the side effects, the common side effects that were reported were like peripheral edema, nausea, vomiting, and the other being the increased blood creatinine. And most of the time, this drug was well tolerated by the patient. To conclude, this result, a preliminary result, are comparable to the previously reported cohorts, which were like 5B and the 6-pencil cohorts that also demonstrated the similar results. The overall response rate was around 51.6% in second line and in the 40.6% to second or the third line. So the median OS, in which the two cohorts in which it is reported, is around 20.8 months, and in the pre-treated cohort, it was around 13.6 months. So there is a manageable safety profile. So updated results showed that this is a actionable and a targetable mutation. So definitely we can use this drug. But few points I want to make, that definitely we need a more data. And being this mutation is common in very elderly population. So compared to the chemotherapy, I think this drug is much more safe to be given. And coming to the side effects, yes, the side effects are very less. And if this drug is not available, the drug crizotinib is also shown around efficacy of 30 to 32% in such case. So with that, I conclude. Thank you so much.
Thank you, Dr. Navdeep. Thank you for enlightening us regarding this uncommon mutation and the role of capmatinib in it. So questions are welcome, and I have a little doubt regarding this from myself also. So what are the patients in which you are testing for MET? Are all metastatic LLC? Do you test for this MET mutation, number one? And number two, what is the TAT for NGS at your center?
So still, I have just started practicing with the time span of 1 to 2 months. Not got any patient, but yes, I recommending it for all the metastatic stage 4 patients.
Okay. So what is the TAT for NGS? Probably 2 weeks or more than that?
I think it's around 2 to 3 weeks also.
Okay, good. Okay, so I have used capmatinib for one patient. Okay. And I started it when it was not launched in India. And so I had to apply through compassionate access program and I had to import it. So if time permits, I think so we have some time, I'll be presenting that case. I have prepared some slides, so we can discuss that also. Just a second. So are my slides visible?
Yes, yes.
Okay.
Yes.
So this is a clinical case. This woman, 69-year-old female non-smoker without any comorbidity, presented to me in the month of June last year. She had cough since 2 months and significant weight loss, around 8 to 10 kilograms. So she got a chest X-ray, which was suggestive of a left upper lobe mass. And then she underwent a PET, which was suggestive of a left upper lobe spiculated mass around 5 centimeter with lytic bone lesions with some mediastinal lymphadenopathy and a minimal left pleural effusion. So we did a biopsy. It was suggestive of spindle cell carcinoma of the lung, a very rare disease. And it is a subtype of sarcomatoid variants of lung cancer. So because this is an uncommon pathological subtype and it is usually not very responsive to chemotherapy, so we didn't go for EGFR, or ALK by conventional. We sent an NGS. We had the discussion with the patient and we waited for 2 weeks. And surprisingly, we had an exon 14 skipping mutation positivity, and it took us around 2 months to import the drug. The patient was started on capmatinib through compassionate access program, and I'm very thankful for Novartis for that. After 3 months of therapy, so here's the PET, which we have a significant response, a significant decrease in size, as well as SUV uptake. And she had a little bit of, pedal edema, which is a class effect, I would say. And we had to, reduce a little bit of dose, but more or less she is tolerating well, and with diuretics and all that. And she's quite better now. She's gained at least 6 to 8 kgs, she's back to normal. Her ECOG PS has improved probably now, I would say 1 to 2. And when she came to us, it was around 4. So I think so. This case, what teaches us is, number one is, if you have somebody with this uncommon histologies like spindle cell or sarcomatoid variants, then I think so you should be definitely suspecting this mutation. Overall, you might find it in probably less than 3 or 4%, but in the subset, approximately 16% patients in some series have this mutation. So I think so. This
just a thing, would you like to test in other spindle cell other than
other
lung?
sarcomatoid.
Yeah.
Yeah, definitely. Because
Okay.
it is enriched in this subset,
Mhm.
definitely. Otherwise, I'm doing a NGS for all my metastatic NSCLC patients,
Okay.
and that would definitely catch it. But for those subsets, probably you should be more suspicious for this mutation. And now we have a targeted therapy for that. I think so. That's one of the reason we should be more even more inclined to test for this mutation.
Dr. Priyanshu, Dr. Alok here, if I can make a comment on this.
Yes, sir. Sure. So thank you.
So I just want to add one thing. It's good we do NGS for those tumors which are rare, but when interpreting the result of NGS, we should know that on all the tumors, these might not be a driving mutation. So where the data is available for driving mutations, so a lot of time what is happening, we are now getting NGS report and we are stuck after NGS report because we don't know whether it's a tier 2 mutation or tier 1 mutation and whether it's a driver mutation or not. So it's good to get NGS done, but we should use the data judiciously, and we should not keep on because these are expensive therapies, and a lot of our patients will not be able to afford them. And while waiting for CAP program, we are making the patient progress on therapies. So based on the data we have, we should order NGS and we should know how to interpret them. So we have to be careful using NGS for all the patients.
Definitely, it's a very valid point. And I think so. It's a off-label. I mean, we can use crizotinib also. Although I'm not very sure that it's also not so cheap, I would say. But now it's available, so I don't think so. Now you should wait for a compassionate access program. Now you can start it directly.
No, I'm just saying about other variants, other type of sarcomatoid variants which Dr. Navdeep asked. So I said in those rare cases where we don't have data, we should not just rely on NGS report where we don't know whether it's a driver mutation or not.
Definitely, sir. Definitely. So thank you, Dr. Navdeep. And now we proceed to the next session.
So I'd like to invite now Dr. Alok Goel, who is Associate Professor, Department of Medical Oncology, Homi Bhabha Cancer Hospital, Sangrur, and he's going to deliver his talk on current perspectives in management of ALK rearranged advanced NSCLC. Over to you, sir.
At the outset, I will like to thank the organizer for giving me this opportunity to be the part of this academic meet. So if my slide set can be shared, and I'm sorry, my bandwidth is a little low, so I will be not sharing my video. Is that okay?
Yes, sir, sure. No issues with that.
Okay. So at the outset, I would like to say that this slide set are provided to me by Pfizer. So mainly in this session, we will be discussing about lorlatinib in the management of ALK3 and NSCLC, and mainly we'll be talking about a CROWN trial which led to FDA approval for this agent in first-line setting. Next slide, please. Next slide, please. So I think this is just the repetition. We all know this, but we know that why it is important to discuss lung cancer. The burden is increasing. We know it's a common cancer of as per incidence as well as mortality. And we know that we have come so far from a histological based diagnosis to a molecular diagnosis. And as we have discussed, the use of NGS, and we have getting more and more mutations, and thus it has become more of a personalized medicine rather than a histologically based treatment now for lung cancer. Next, please. This is just to show that lung cancer is not static. The incidence is increasing, and it is predicted that by 2040, the number of patients with lung cancer will almost double of what it is now, and so is the mortality. So more and more effective therapies and more understanding of these rare mutations and newer drugs will be needed for practicing medical oncologists more than before. Next slide, please. Next slide, please. Next slide, please. So we'll start with a brief discussion on ALK mutation. So ALK is one, ALK gene renal lung adenocarcinomas are variable, and the incidence varies based on the demography we are studying and the type of population we are studying. So this is one study which is from Dr. Navee's group from PGI Chandigarh, where they studied the incidence of mutation in their population, and it was found to be 8% from North India. The percentage of this mutation varies from somewhere between 2%. We had a TMH movement where we studied the incidence of this mutation, and the rate was almost around 6 to 8% in our subset also. Next slide, please. Next slide. Yeah. So as we know, as with EGFR, we know that there is some morphological characteristics which are more seen in this mutation, but they are not pathognomic of these mutations, and we need to do testing for this mutation before starting treatment. So what is more common is this? These are mainly adenocarcinomas. Rarely, less than 1%, we have few patients which are squamous morphology and ALK. Therefore, now NCCN also recommends doing EGFR ALK mutation in squamous cell lung carcinoma also, although the percentage is rare, less than 1 to 2%. They are typically, but not always. So that has to be seen, so that we should not restrict doing these mutations in patients who are smokers. So they are more common in non-smokers, but they are found in a small subset of patients who are smokers also. They occur in a younger patient, as seen with EGFR. And there are different partners for ALK mutation, with the most common being EML4. Although we used to think that EGFR and ALK are mutually exclusive, but there are case reports. We have case reports from Tata also, where we have found that there are few patients who have a mutation of EGFR as well as ALK, and the management of these is beyond the scope of our discussion at present. Next slide, please. So just to understand that what is this EML4 ALK fusion? So it's a type of inversion rearrangement where the part of chromosome 2, where the ALK gene is present, get broken and get fused with EML4 gene, resulting in a EML4 ALK fusion protein, which leads to a constitutionally active tyrosine kinase, which leads to uncontrolled cell growth. Next slide, please. So before going to this, I will just like to say that various methodologies for testing ALK, there are 3 methodologies which are recommended by US FDA. One is NGS, second is IHC, and third is FISH. And I would like to make a point here. So in this ALK mutation, we know that the FISH and the IHC has concordance, and so a simple test like IHC is good enough, and we don't need to repeat a FISH or NGS to get a ALK mutation. But as tissue is the issue, so we normally get NGS as the number of mutations are increasing, and we need to save the tissue. But IHC is concordant with a FISH in almost 97 to 98% of population. So if we look at the timeline of ALK inhibitor development, we can see that the discovery of this mutation or translocation occurred in 2007, and the first line therapy, which is crizotinib, came after 5 years. And after that, there is a lot of development which have occurred, and we have now second generation as well as third generation agents
which are there. And now in 2021, lollartinib, which is third generation ALK inhibitors, has been approved in first line also. So this talk we will primarily discussing about the CROWN trial, which led to the FDA approval of lollartinib first line. Can we move to next slide, please? So what are the current treatment options in ALK positive patients, and why is there unmet need despite all these armamentarium of agents which we have there? So as we can see that ALK positive patients are generally young and they are light smoker. So they have a lot of life which is pending, and giving a good quality of life and increasing survival become important. ALK patient have a predispensity to have CNS metastasis, which is seen in almost 20 to 40% of untreated ALK patients. And so it's a significant challenge because a lot of agents have a restricted entry into brain. As we know, as with EGFR, there are a lot of resistance mechanisms which are present when patient progress on first-line therapy, and these leads to resistance to present drugs. Next slide, please. So a bit about lollartinib. So lollartinib is a selective ATP competitive potent third generation ALK TKI. So what is important to know, which differentiate it from other, is it has excellent brain penetration, almost 75%. Secondly, it is active in resistant clones like G1202R, where other ALK inhibitors, even the third generation like brigatinib, are not effective. So this is where it is different from other ALK inhibitors, and there is a place for this agent in the armamentarium of ALK inhibitors as we move forward. Next slide, please. Next slide, please. Next slide. Next slide. We have already talked about. Yeah. Next slide. So now let's talk about the CROWN trial, which led to the approval of lollartinib in first line. This was a randomized multi-center study. Next slide, please. So this is a study schema. So this was a randomized multi-center study which enrolled patients with frontline ALK positive NSCLC. It included patients with stage 3B, mainly metastatic patient with ALK positive non-small cell lung cancer, frontline patient with ECOG up to 2. They included patients with asymptomatic, treated or untreated CNS mets, and they should have at least a site of measurable extracranial lesion. They were randomized 1:1 to either lollartinib or quizartinib in standard dose. There was a pre-stratified subgroup by presence of brain mets as well as ethnicity, which they wanted to study. And the primary endpoint of the study was progression-free survival by a blinded independent central review. So there are two things which I want to highlight in the study schema. So they have included patients even with PS2, which is rarely seen in clinical trials now, and which is more in line with the clinical type of patient which we see in our practice. And they have included patients with CNS mets. Secondly, a lot of trials now have PFS, which is by investigator, which lead to some biases, but they have taken PFS by independent central review as their primary endpoint. And they have secondary endpoints of PFS, intracranial PFS, intracranial response rate, overall survival, safety, as well as quality of life, which is important nowadays when we are talking about these type of agents. Next, one more point which I want to highlight is there was no crossover which was allowed in this trial. So they enrolled 296 patients, which was through 23 countries, and they were equally divided between the two arms. They imaged these patients for restaging every 2 weeks with abdominal CTs as well as brain imaging. So what we can see at the interim data cut, which was at 20th March 2020, there was 103 patients in the lorlatinib group and 31 patients in the quizartinib group who already were on treatment, so that they were not progressed. And the median duration of follow-up for the lorlatinib arm was 18.3 months and 14.8 months was for the quizartinib arm. Next slide, please. Next slide. So the baseline characteristics were fairly matched between the two groups. Previous slide. Yeah. But there are a few things which I'll like to highlight. So the median age of the study group was in between 56 to 60, which is what we clinically see in our patient also, that the ALK quality patient are falling within this age group. They divided the patient into white, Asian, and other ethnicities, and we could see half of the patient were white and half were Asian. Although they mentioned that they included ECOG PS2, what was disheartening to see that there were only 2 patients in the lorlatinib group and 6 in the quizartinib, which was in PS2 group. I would have liked it to be more realistic and more patients in a poor PS, which is usually the case what we see in clinics. If we can see, most of the patient were a never smoker and our previous smoker. That is what the subset of ALK quality patients are. And almost 1/4 of the patient in both the groups have brain metastasis at presentation. Can we go to the next slide, please? So if we look at the primary endpoint, which is the PFS, this is nothing to explain. The curves explain themselves. There is an early separation and a progressive separation of the two curves with a beautiful separation of the two curves between each other. And we can see there is almost a doubling from 38% to 39% to 78% at 12 months of the PFS, which is very unlikely to see in trials nowadays. Which are rare in first-line trials nowadays. So if we can see the events which were there were only 41 in the lorlatinib arm and 86 events in the quizartinib arm, with a median PFS of 9.3 months in the quizartinib arm, which we already know from the historical data, and the median PFS is not reached in the lorlatinib arm, and the hazard ratio is a healthy 0.28, leading to a 72% relative improvement in PFS. Next slide, please. The secondary endpoint of PFS by investigator also show the same results. There's a 80% PFS at 1 year in the lorlatinib arm versus 35%, which is similar to what is seen by independent center review. Next slide, please. So if we look at the forest plot and try to understand what all subset of patient benefit with this therapy, we can see it's rare to see this type of forest plot nowadays, with all the subgroups having a significant benefit with the hazard ratio, which is in the range of 0.2 to 0.3, showing that lorlatinib benefits patient across subgroups, whether they have brain mets or not, whether they are Asians or non-Asians, despite of PS, the sex, the age, and the smoking status. Next slide, please. So if we look at the response rate also, what is good to see that there are 4 patients even in the stage 4 group who have complete response, and 73% patients have partial response as compared to 58% in the quizartinib arm. So this is very good to see, because with the decrease in burden of disease, there is a definitive increase in the quality of life of the patient, and it gives us confidence in the therapy. And if we see, the median time to response is also 1.8 months, which is similar with quizartinib, and the median duration of response is 11 months with quizartinib, and it is still not reached in the lorlatinib arm. Could we go to next slide, please? So if we look at the intracranial response rates in this patient, which is, we know that lorlatinib has a good CNS penetration, and we expect it to have good response rates in CNS, and it has not disappointed us. So if we can see, out of the 38 patients who have miserable brain metastasis at baseline, 66% have responded, as compared to only 20% in quizartinib group And if we look at the complete response in brain, which is rare to see, almost 61% patients out of 38 have a complete response in brain as compared to 15, which is very good to see. If we look at the patient with measurable brain mets also, we can see that 71% patient, that is 12 out of 17, have complete response in brain. So this help us in avoiding therapies like WBRT or radiation therapy, and we can have good response with these therapies. So we can avoid multimodality therapies in these type of patients. Can we go to next slide, please? So this type of flat curve, I need not explain that thing, but if we look at the intercranial time to progression, we can see almost none of the patient on lorlatinib had progressed within a median follow-up of 33 months. So if we see only 5 patients out of 149 in lorlatinib had intercranial progression as compared to 45 in the quizartinib arm, and the hazard ratio 0.07, which is very, very good. Can we go to next slide, please? Although overall survival was a secondary endpoint and the data was not mature enough to comment on overall survival, still the hazard ratio was 0.72, but the confidence interval was crossing unity. But as I said, it's not a primary endpoint, and the data was not mature to study OS, so we could not comment on overall survival. Could we go to next slide, please? So this is the most important slide which I want to look. When we look at the when we have to look at the efficacy, we have also to balance it with the safety of the agent, and that is important to know. So if we see, almost every patient in either the quizartinib or lorlatinib group had any grade of side effects, with almost 72% of patients in lorlatinib group having grade 3 to 4 side effect as compared to 56% in quizartinib arm. And serious adverse effects were comparable between the two groups, being almost 30% in both. There were 7 events which were fatal in both the groups. And if we look at the patient who have to discontinue treatment because of side effects, this was low. This was not much. This was 7% in the lorlatinib group, which was comparable with quizartinib. And the temporary dose interruption was also comparable in both the groups, saying that although it has more grade 3 and grade 4 side effects, these are mainly laboratory, as you will see in the next slide. And patients' outcomes and the patient discontinuation.
So I request you to conclude your session
Sure.
in 2 minutes.
Sure. So if we see as the side effect profile, we can see that mainly the side effects which are worrisome in these patients are hypercalcemia, hypertriglyceridemia, which are a different side effect which are seen with lorlatinib, which is not seen in other type of ALK inhibitors. Other type of side effects are not worrisome with this type of patient. Can we go to next slide?
Sorry to interrupt. I think so. We can take another 5 minutes, so not an issue.
Okay. So if we look at the quality of life score, when we are looking at a newer therapy which is more effective, we should always look at the quality of life, whether they are not decreasing the quality of life of the patient. In this regard, we can see that if we see the global quality of life score, which are studied by EORTC C30, which is the most standardized score for QL, we can see that the quality of life deterioration was not seen as much with lorlatinib as with quizartinib. So there is a preservation of quality of life, and that is mainly because of potency of this agent leading to decrease in disease burden, so that the patient has a better quality of life. Can we go to next slide? So to conclude, lorlatinib, as we saw, resulted in a significant longer progression-free survival, significantly higher overall and an intercranial response, and an improved global QOL compared to quizartinib in the first-line treatment of ALK-positive non-small cell lung cancer. If we have to see, the intracranial response rate were 82% in patients with measurable brain mets, with a complete response rate of 71%, which is very, very impressive, and a significantly longer time to intracranial progression. The safety profile of lorlatinib is same as what we know from the phase 2 studies, which have led to approval in second-line studies. And the grade 3-4 adverse effects are mostly laboratory, and they can be managed with some temporary discontinuation or some decrease in dose of the therapy without affecting the efficacy of this drug. So these results support and are approved for the use of lorlatinib for first-line therapy of patients with advanced ALK-positive non-small cell lung cancer. Next slide, please. Next slide, please. So one slide which I want to highlight is, because we see almost 3/4 of the patients on lorlatinib had hyperlipidemia. So to know how to manage it become paramount when we are managing these type of patients. And it is not difficult, as we can see from a trial. Decreasing dose of the therapy to to a step down, or using fairly well tolerated agents lead to management of these hyperlipidemia. One or two points which I like to highlight is lorlatinib is metabolized through CYP3/4A. So strong inducers or inhibitors of CYP3/4A should be avoided when using lorlatinib. In this respect, atorvastatin, which is the most commonly used statin, is metabolized through CYP3A4, and it should be avoided in this patient. And if we have to use statin, rosuvastatin or pravastatin should be the agent we are using. Similarly, when we are managing hypertriglyceridemia, which can occur because of this agent, genofibrate should be avoided because of CYP3/4A interaction, and other fibrates are the one which should be used. And if we look at an individual patient data from the study, most of the patient with a single step down reduction in dose from 100 to 75 were able to continue therapy with manageable lipid set points, and they did not need to discontinue treatment because of this side effects. Can we go to next slide? Second side effect which are highlighted, which are seen more commonly with lorlatinib as compared to other ALK inhibitors, is CNS effects, and which are obvious because of its higher CNS penetration. But what is important to see is only 24 patients, that is only around 15% of these patients, require dose modification for these CNS side effects, and most of these patients are able to tolerate this drug with this dose modification and doesn't lead to dose discontinuation in most of these patients. Next slide, please. Next slide, please. Thank you, and sorry for prolonging the time.
Thank you, sir. Thank you for such a wonderful data. And if you have any questions, you can ask.
Yeah, I will be happy to answer any queries if there are any.
Dr. Piyush, you have to unmute, I think so.
I will be happy to answer any queries if there are.
So Dr. Piyush is asking something, I think, but his voice is not audible.
He can write on chat box if he wants, or we can take it.
Sir, I have one question. How often do we monitor the metabolic side effects like hypertriglyceridemia and all that?
So as per the guidelines, or as per the product outlet, they said that within the first 8 weeks, it has to be done 2 weekly. And if they are fairly well, then we can increase it to monthly, and later on to even 2 monthly if the patient continues to have lipid levels which are controlled. So 2 weekly for the first 8 weeks which is recommended.
So, sir, Dr. Piyush has asked that what is your opinion on first line use?
So this is a very hard question he's asking. So with the armamentarium which is increasing nowadays, with alectinib also, which is showing very effective data, and the lorlatinib data which is now coming up, the place is very crowded. So what we have to understand is when we are deciding on a first line therapies, what are the options for the further line of therapies? Because nowadays this is not a sprint, it's a marathon which we are running, and the more the number of effective agents we are able to use, the more the survival we are able to provide to our patient with a better quality of life. So my first line preference till now was alectinib. But I would like to highlight there are some subset of patients which we would like to use lorlatinib. Those who have resistant mutations like G1202R, where no other ALK inhibitors are effective. A patient where you want a rapid response intracranially, with lorlatinib having a significantly better intracranial penetration. These are the type of patient which you will want to use an effective therapy upfront, because you don't want to wait for a second line when some of these patients might not be eligible for the second line therapy. So we have to balance using or keeping these agents for second line versus using them front line when the patient is most fit for using these agents. So there is no right answer. Both alectinib, brigatinib, lorlatinib are effective drugs. They have shown effective data, and it is going to be very difficult to choose one in the first line. So it's based on the side effect profile, the patient preference, the cost, the PAP program. More competitive PAP program we have, more the number of patients who are able to afford our agent will be one which are deciding, and there is no clear winner as of now. Alectinib being the OS data which is more mature seems to be more logical first line therapy as of now, but with more and more data for lorlatinib coming in, the picture will become more clearer as the time progresses.
Sir, what is your personal experience with this drug? Because I mean, what are the common side effects, which you have seen, and how have you managed them?
I have used it in TMH when as a compassionate. We have used it as a compassionate based in one or two patients. So yeah, CNS side effects are seen. Patients have some cognitive and mood effects which are seen with these agents. And yeah, metabolic are problem, but most of these are managed with dose reductions or temporary discontinuation. Although I couldn't follow these patients long data and join some group to give you a long term this patient. So honestly, I don't have a long term personal experience of using these agents to tell you what to expect in long term, but short term they seem to be manageable. The side effects seem to be manageable.
So just like we do with crizotinib and all that, do we need ECGs for lorlatinib also?
No, so QT prolongation or bradycardia, which is a significant side effect of crizotinib, is not commonly seen with. So unless the patient is symptomatic or you touch the pulse and you feel bradycardia, you don't require. We do it as a baseline, but you don't require it as a monitoring parameters in lorlatinib for asymptomatic patients.
Okay. Sir, I have used it in 2 patients, and both of these patients had manageable pedal edema, and one of these patients, both of these also had CNS side effects with mood disturbance. One was actually admitted in ICU with pleural effusion, so I'm not sure there was some confounding variable also. But with the stoppage of the drug, then she recovered, and I had to do some dose interruptions with this. So I think the CNS side effects are not that uncommon, I think so, with this drug, because you also have faced this.
So if you look at the data, the serious side effects were mainly metabolic. There were some fatalities which were seen both in crizotinib arm as well as lorlatinib arm, and we have to accept it when we are looking at patients with brain metastasis, and we are including these type of patients. We will be expecting these type of side effects which are coming, but we have to look at the brighter side. When we are going for efficacy, we have to trade it with some of these agents, but these are not that much to be too alarming when we are using data. But monitoring is paramount, and every oncologist, when using these, should know how to monitor the side effects and should not ignore the side effects, should know how to pick up the side effects and do dose reduction in time so that these can be managed in time.
Definitely, sir.
Thanks a lot. Thank you.
Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, sir. And next we move on to next speaker, Dr. Priyanshu Choudhary, who is consultant medical oncology, Shalby Hospital, Mohali, and he's going to deliver his talk on long-term survival outcomes with nivolumab in NSCLC. Over to you, sir.
Thank you. I'll be sharing my screen. So are my slides visible?
Yes, sir. It's visible. Just make it to full screen. Yeah, now it's okay.
Okay, just a second. Okay, a very good evening to all of you. And I would like to thank BMS for giving me this opportunity. So today we'll be discussing regarding the long-term survival outcomes with nivolumab in metastatic non-small cell lung cancer. So the overview of the presentation would be, we'll be discussing the NSCLC overview and treatment landscape. And we will be discussing the joint analysis of two trials, that is Checkmate 017, 057, and the 5-year outcomes with nivolumab in previously treated advanced NSCLC. So coming to the disease burden, we all know that lung cancer is the most common cancer worldwide with respect to incidence. It represents 13% of all cancers at diagnosis. It is also the most common cancer leading to cancer-related mortality worldwide and accounts for 19% of all cancer deaths. Among men, 24% of all, almost 1/4 of all cancer deaths are due to lung cancer, and it is the leading cause of cancer death among men. Among women, it is the second leading cause of cancer death, accounting for 14% of all cancer deaths in females. So lung cancer accounts for more annual deaths than colorectal, breast, and prostate cancer combined. A staggering 1.59 million deaths are due to lung cancer. And if we compare it with colorectal, it is around 7 lakh, breast around 5.2 lakhs, and prostate around 3 lakhs. So it is the leading cause of cancer-related deaths in both sexes combined also. So coming to the histology and staging, we all know this lung cancer divided into two: small cell lung cancer accounting for 10 to 15% of all lung cancer patients, and the majority, that is 80 to 85%, is non-small cell lung cancer, which can be further divided into squamous, non-squamous, uncommon histologies, and it is divided usually, which is distinguished on histological types based on size and shapes of cells, site of origin, rate of growth, correlation with smoking history. So coming to the stage-wise incidence, if we see that only around 16% of the patients are present in the early stage at diagnosis, that is stage 1 and stage 2. Stage 1 is when the primary tumor is 3 to 5 centimeter and localized 3 to 5 centimeter with localized lymph node, is stage 2. And stage 3, which is usually the locally advanced lung cancer, presents in around 22% of the patient. And stage 4, that is metastatic tumor, is present in majority of the patient, that is 57% of the patient present in a metastatic stage at diagnosis. So again, this is the TNM classification: early stage, that is stage 1 and 2, locally advanced, that is stage 3, and metastatic is stage 4. So now coming to the Indian data, the lung cancer epidemiology in India. Lung cancer in India, we have around 72,500 cases every year, with a cumulative incidence of 5.5 per lakh population. And lung cancer leads to around 66,000 deaths every year in India. And the 5-year prevalence is around 80,000. Now coming to the second line therapies in non-small cell lung cancer, the improvements in first line therapy standards for advanced non-small cell lung cancer has led to patients experiencing longer disease-free survival intervals and with a greater likelihood of having a good performance status at relapse. And improved performance status meant patients were likely to be eligible for further treatment upon relapse, establishing a role for second-line chemotherapy for more patients. Docetaxel was the first agent approved by FDA for second-line therapy, and targeted therapy options also exist. Agents targeting the PD-1 and the PD-L1 axis have transformed the management of NSCLC and have now emerged as a new standard of care for previously treated advanced non-small cell lung cancer. So what are the treatment consideration in advanced or metastatic non-small cell lung cancer? The treatment decision begin with histology and molecular pathology. So we have to see whether it's squamous, non-squamous, what is the disease biology, what is the sites of disease, and we look at the prognostic factors. So performance status, stage, age, smoking history, the lines of therapy, weight loss, comorbidities, absence of extrathoracic tumor lesion at initiation of third line treatment, and longer time since last chemotherapy. So these are the prognostic factors which have been found in various trials and have shown to affect the survival. The predictive factors are the factors which predict the survival outcomes and the response to therapy. So these include response to first line treatment, whether it's a partial response or a complete response or stable disease, and the disease control rates after first and second line treatment. Third, treatment decision consideration includes treatment benefits and toxicities. Both financial toxicities should also be considered, and patient preferences. So if we see the systemic therapy option in advanced non-squamous NSCLC, if they are negative for a driver mutation for EGFR, ALK, and ROS1. So the guidelines suggest that a good performance status patient, that is PS0 to 2, should receive systemic therapy in the first line. And if there is a response or stable disease, then patient should be continued on maintenance therapy. The maintenance can be bevacizumab or pemetrexate, or a combination of bevacizumab plus pemetrexate, or even gemcitabine, which is a category 2B indication. You can also go for a switch maintenance with pemetrexate or close observation. Upon progression, if the patient still has a good PS of PS0 to 2, then immune checkpoint inhibitors are preferred. Nivolumab has an NCCN category 1 indication and an ESMO MCBS rating of 5, or pembrolizumab or atezolizumab, or other systemic therapies like docetaxel or pemetrexate, or gemcitabine or ramucirumab plus docetaxel. So if on progression or at baseline a patient has a performance status of 3 to 4, then best supportive care is the usually recommended option. So coming to systemic therapy options in advanced or metastatic squamous non-small cell lung cancer. So again, in a good performance status of PS0 to 2, first line systemic therapy, which is usually a taxane and carboplatin combination. If there's a response or stable disease, then maintenance in this setting, that is squamous, is a category 2B indication. It is not a category 1 indication. So you can continue with gemcitabine maintenance, or a taxane as a docetaxel maintenance, or with close observation. So upon progression, again, if the patient has a performance rate of 0 to 2, then the preferred immune checkpoint inhibitors are nivolumab with NCCN category 1, and then ESMO, a magnitude of clinical benefit scale of 5, or pembro, again NCCN category 1, or atezolizumab, it is also category 1. Other systemic therapies include docetaxel or gemcitabine or ramucirumab plus docetaxel. At progression or at baseline, if a performance status is PS3 to 4, then best supportive care is the recommendation. So now coming to the data of the 5-year outcomes from the randomized phase 3 trials, CheckMate 017 and 057, which compared nivolumab versus docetaxel in previously treated non-small cell lung cancer. So the background, if we see, what is the usual 6-year overall survival rate in non-small cell lung cancer patients? In the CheckMate 003 trial, if we see the median OS was 9.9 months in the nivolumab arm, and you see, if you can see, the 6-year overall survival in this study was close to 15%. Now coming to these two studies, that is CheckMate 017 and 057. And if you look at the study designs, the common eligibility criteria were stage 3B to 4 NSCLC with the Eastern Cooperative Performance status of 0 to 1, and patient were allowed to have 1 prior platinum-based chemotherapy. In the Checkmate 017 trial, which included 272 patients, squamous non-small cell lung cancer patients were taken. And in the Checkmate 057, which had 582 patients, non-squamous NSCLC patients were taken. And prior TKI therapy was allowed for known ALK translocation or GFR mutation, and prior maintenance therapy was also allowed. So the patient were randomized 1:1 to nivolumab, 3 milligram per kg every 2 weekly, and docetaxel, that is 75 milligram per meter square IV Q3 weekly. The primary endpoint was overall survival, and the additional endpoints included PFS, overall response rate, efficacy by tumor PD-L1 expression, the safety, and the patient-related outcomes. And the treatment was continued until disease progression or unacceptable toxicity. Coming to the 5-year pooled overall survival, in the nivolumab versus docetaxel, nivolumab delivered nearly 5 times the 5-year overall survival rate. The median overall survival in the nivolumab arm was 11.1 months compared to 8.1 months in the docetaxel arm. The hazard ratio was 0.68. That is, there was a 32% relative reduction in the risk of death in the nivolumab arm. So this is very important that if we see the 12-month overall survival rate is close to 50%, and the nivolumab arm 48% versus 34.3. Then again decreases to 27% roughly in 2 years and 17% at 3 years. But even at the end of 5 years, that is at 60 months, if we see around 13.4% patients were alive in the nivolumab arm compared to just 2.6% patient in the docetaxel arm. So there is an almost 5 times the overall survival has been shown to be nearly 5 times in the nivolumab arm compared to docetaxel arm. Now, then this pool analysis was, further analyzed according to the PD-L1 status. And if we see the 5-year pooled overall survival in patient who had PD-L1 more than 1%, at 5 years, nivolumab demonstrated unprecedented survival in expressors, that is in patients who were PD-L1 positive, PD-L1 more than or equal to 1%. So the median overall survival in this subgroup of patient in the nivolumab arm was 13.4 months compared to docetaxel, which had a median overall survival of 8.5 months. The hazard ratio was 0.61, which was significant. And again, if we look at the survival rates in the PD-L1 positive population, at 1 year, it's 53.5% in the nivolumab arm compared to 34.3. At 2 years, it increases to 31.7 versus 15.2 in the chemotherapy, slowly dipping. But even at the end of 5 years, if we see this almost a plateauing of the overall survival curve. At 5 years, around 18.3% patient in the PD-L1 positive group who had received nivolumab were alive compared to just 3.4% patients in the docetaxel arm. Now coming to the analysis of patient who were PD-L1 negative, that is PD-L1 less than 1%. Even these patients derived benefit with the use of nivolumab, although the absolute benefit was less. If we see nivolumab, the median overall survival in the nivolumab group in patient who were PD-L1 negative was 9.7 months compared to 7.8 months in the docetaxel arm, and the hazard ratio was 0.76. And again, if we look at the curves, around at 1 year, 44.8%, less than half of the patients compared to 33.5%. At 2 years, 23.7 versus 13.4. At 3 years, 11.6 versus 6.7. But at the end of 5 years, 8% patients were alive in the nivolumab arm in the PD-L1 negative subgroup compared to 2% in the docetaxel arm. So although it's around 4 times more survival, but I would say the overall percentage is pretty low. So if we see if we see the data stratified by the pathology, at 5 years, nivolumab showed durable long-term overall survival in squamous metastatic non-small cell lung cancer also. So, in the Checkmate 017, which had squamous NSCLC patients, at the median follow-up of 62.6 months, the median overall survival in the nivolumab arm was 9.2 months, compared to 6 months in the docetaxel arm, with a hazard ratio of 0.62. Again, if we see the 1 year survivals, 42.2% versus 24.1%. In the chemotherapy arm. At 2 years, it has dipped to 23% versus 8%. 3 years, 15.6 versus 5.8. And at the end of 5 years, if we see patients metastatic NSCLC who were squamous cell carcinomas had a 5-year overall survival of 12.3% in nivolumab arm compared to 3.6% in the docetaxel arm. Now coming to the non-squamous cell metastatic NSCLC, at 5 years, nivolumab showed durable long-term overall survival even in the non-squamous metastatic NSCLC. The analysis of Checkmate 057, which included non-squamous metastatic NSCLC, at the median follow-up of 62.7 months, the median overall survival in the nivolumab arm was 12.2 months compared to 9.5 months in the docetaxel arm, with a hazard ratio of 0.70. And again, if we see at 1 year, a little more than half of the patients were alive, dipping to 28.7% in at 2 years in the nivolumab arm and 16.1 in the chemotherapy arm. Further dipping to 17.7% at 3 years and 9.4% in the chemotherapy arm. At 5 years, 14% of the patient who were non-squamous metastatic NSCLC were alive at in the nivolumab arm compared to just 2.1% in the chemotherapy arm. So almost 7 times the overall survival was achieved in the nivolumab arm compared to chemotherapy arm. Now coming to the subgroup analysis, the overall survival subgroup analysis showed that nivolumab was beneficial in almost all the subgroups in both sexes, in PS0 or 1, in age less than 65 or more than 65. Although in more than 75, the hazard ratio was more than 1. But the numbers were pretty less, that is only 72. So it is very hard to comment. In both the histologies, it showed benefit slightly more, I would say, in that ratio is better in squamous. And in both PDL1 positive as well as negative, that is more than 1%, more than equal to 1% or less than 1%, nivolumab showed benefit. Hazard ratio slightly better in patient who had PDL1 positive disease. So nivolumab showed benefit in almost all the subgroups and with respect to overall survival. Now coming to the 5-year pooled PFS duration of response. So if we see at 5 years, nivolumab demonstrated a sustained duration of response and a median PFS of 2.5 months compared to 3.5, but it was favoring nivolumab with a hazard ratio of 0.79. At 1 year, around 20% of the patient had the disease control, tapering down to around 8% at 5 years, with none of the patient and the docetaxel having been on therapy at the end of 5 years. So the duration of response was again significantly prolonged in the nivolumab arm. The median duration of response was 19.9 months in the nivolumab arm compared to 5.6 months in the docetaxel arm. We see again the patients who were in response was at 1 year, it was 60% in the nivolumab arm compared to 15.2% in the docetaxel arm. At 2 year, it dipped to 48.6 versus just 5.1. And post 3 years, there were no patients on docetaxel, while at the end of 5 years, almost 1/3 of the patient, that is 32.2% patient, had a response on nivolumab. So nivolumab shows a durable survival benefit in responders, that is in patient who had a complete or a partial response. So the pooled 5-year analysis, extended overall survival analysis also showed that nivolumab improved overall survival in patients who were responders, that is who had a partial or complete response. So in this subset, at 5 years, the Checkmate 057 and Checkmate 017 pooled overall response rate for nivolumab was close to 20%, that is 19.7, versus 11.2% for docetaxel. And the median overall survival in patients who were responders was not reached in the nivolumab arm, even at the end of 5 years, compared to 16.4 months in docetaxel. And the median duration of response was 19.9 months in the nivolumab arm compared to 5.6 months in the docetaxel arm. So if we see at the end of 1 year, 87% of the patients who were responders were alive. At 2 years, they were 65%, 3 years, 58%. Even at the end of 5 years, more than 50% patients were alive. Of the responders were alive in the nivolumab arm compared to just 6% in the docetaxel arm. So, a response is quite predictive of a prolonged overall survival. And if we can see that the curves have separated almost by the time of 9 months. So again, the PFS and overall landmark analysis by PFS at 2, 3, and 4 years. So a 2-year progression-free survival a 3-year progression-free survival of 76%. And out of these, again, 68% patients again reached up to 5 years with respect to overall survival. And almost 60% of the total group who were progression-free at 2 years were alive at the end of 5 years. Similarly, 93% of the patients who were progression-free at 3 years were alive at 5 years, and around almost all the patients who were progression-free at the end of 4 years were alive at 5 years. So coming to the baseline characteristics, the baseline characteristics were usually well matched in both the arms, except for the ECOG PS0 and PDL1 expression more than 1% in the nivolumab arm. So if we can see, a majority of the patient were less than 65 years of age and had a PS1, and the majority of the patient were current or former smokers, and around 90% of the, more than 80% of the patient were stage 4 disease. And non-squamous histology was the predominant, 65%, 65 to 70%, and PDL1 expressor were almost equally balanced in both the subgroups. So if we see this flow diagram, the 5-year survivors, 50 patients in the nivolumab arm, out of these 21 who had progressed, 18 progressed on nivolumab and 2 did not receive further therapy. 19 received further therapy, 7 received immunotherapy, and 12 received other therapies. Patients who did not progress, there were 21 patients, and out of these 16 were still on nivolumab at the time of data cutoff, and 5 were off nivolumab because of treatment-related adverse effects or maximum clinical benefit or adverse effect unrelated to study drug. In the 5-year survival on patient on docetaxel, there were only 9 patients, and out of these 8 had progressed and received subsequent therapy, which included 6 patients who had received immunotherapy, and 1 patient was censored. So if we see the safety summary of nivolumab over time, patients on treatment with first treatment-related adverse effects have decreased over the years, and in the first year, the treatment-related side effects, which were common like skin, GI, pulmonary, endocrine, hepatic, renal, these have decreased over time. So at the 3 to 5 years follow-up, there were 26% patient had any grade side effect, with the most common being diarrhea, asthenia, confusional state. But there was only one grade 3 or 4 toxicity, that was increase in the lipase level. So overall, 68% patient with treated with nivolumab had treatment-related adverse events, but only 11% had grade 3 or 4 events. Since a 3-year follow-up, one additional patient in the nivolumab group experienced a treatment-related adverse effect leading to discontinuation, and the patient had a grade 2 nummular eczema, and no new treatment-related deaths have occurred. So to summarize, I would say in a pooled analysis of two large phase 3 trials stopped early due to superior overall survival, Opdita, that is nivolumab, delivers at more than 5 years of survival in second-line metastatic NSCLC in a broad range of patients. And it has delivered 5 times the overall survival rate at 5 years compared to chemotherapy. 13.4% overall survival at 5 years versus 2.6% with docetaxel. And this is the longest follow-up of any 2 phase 3 trials of any immunotherapy in second-line metastatic non-small cell lung cancer. And the overall survival benefit was across different patient subgroups and patients achieving a response. So there was improved overall survival across PD-L1 expression level and histology. So it was better in PD-L1 expressor, and durable survival benefits was achieved in patient achieving a response, that is CR or PR or stable disease. The patient who were responders to nivolumab had an overall survival which was significantly greater than docetaxel, with a median overall survival was not reached at 5 years. So patient without disease progression at 2 and 3 years after treatment with nivolumab had a 60% and 78% chance of remaining progression free at 5 years. At 5 years, 10% of nivolumab survivors were off study drug and they had not progressed and had not received subsequent therapy. With 5 years minimum follow-up, no new safety signals were identified for nivolumab, and there was no evidence of late onset grade 3 or 4 treatment-related adverse effect. These are some external compliance factors, internal compliance factors, and these are the BMS procedures. So thank you, and over to you, Ekta.
Thank you, sir. Thank you so much for the wonderful presentation. And next we move on to Dr. Pratim Sareen, who is Director, Department of Medical Oncology, IVY Hospital, Delhi. And he's going to talk on role of atezolizumab for first-line treatment of MNSCLC recent advancement. Over to you, sir.
Good evening, sir, and welcome.
Thank you. Thank you, Priyanshu. Really appreciate your initiative. But I would really request please try and concentrate on lesser topics. It's a very long date here, and
I'll try to keep that in mind.
Yeah. Because there are so many great speakers we have brought in, and it was a really good hearing that. Good to hear Dr. Ulhas and his usual wonderful presentation, and that's very nice. Anyways, we move on from PD-1 antagonist to PD-L1 antagonist, and Dr. Priyanshu has spoken about that, and my slide deck or my session is sponsored by Roche. Can someone share slides for me?
Ekta, can you do that?
Yeah, Surbi, do you have a?
I'll try to share. Let me check. Is my screen visible?
Yes, sir. Yes, sir. Very much. Just make it full screen if you can.
Okay. I think it's visible.
Yes, sir. You go right.
So a wonderful data shown by Dr. Priyanshu about the second line usage of anti-PD-1 or checkpoint inhibitor, which was actually the first checkpoint inhibitor to be seen. And now we go on to a PD-L1 inhibitor, and atezolizumab or Tecentriq is, I think, an easier way to pronounce it. And we are going to see 3 trials, IMPAR 110, 130, and 150, addressing 3 different issues and its role mainly in the first line, we'll see. So my presentation involves disease background. I won't take it in detail, evolving landscape, just one slide, and then I'll straight away go down to the agenda of IM Power 110, 130, and 150 study. I like this slide a lot. NSCLC, slow growing tumor, I can say, as compared to SCLC, since now SCLC is also having immunotherapy along with chemotherapy. Accounts for 80 to 85% of all lung cancers. 15% of patients are never smoker. Median age of 70 years, typically present with cup, chest pain, dyspnea. In India, it's a bit younger. Metastasis occur later in the disease process. 55% of patients have distant disease. It was shown by Priyanshu. Targeted agents have improved the survival rates. Yes, patients who receive targeted therapy, they have much longer survival, or who have identifiable and targetable driver mutations, they have much better survival. But what about for those who don't have any driving mutations? So this was the evolution. I've seen this evolution during my oncology career. And yes, initially we used to fight for this chemotherapy for this particular histology and this chemotherapy for that particular histology. And then came anti-angiogenics and somehow bevacizumab made inroads into the chemotherapy regime, followed by maintenance, and then finally pemetrexed in adeno, and maintenance pemetrexed led to improvement in survival in the first line. And then came the era of targeted agents. Initially, the actual targets were not really identified. We used to see EGFR amplifications at that time, but Jeftinib, was still considered a wonder drug, and the effect of Jeftinib in some patients was considered equivalent to Lazarus phenomena. Lazarus means it was magical. And then when the exact mutations were identified, first in EGFR, then in ALK, then in ROS, and now there are so many targetable mutations we have, and equally we have the drugs to target them. But still a larger chunk of non-small cell lung cancers don't have an identifiable targetable mutation or an identifiable target, or which are, we can also say, wild type non-small cell lung cancers. And this was what I was talking about. The ones who have a targeted therapy available, they fare much better as compared to non-targeted cytotoxic therapy, and the hazard ratios are in the range of 0.47. So we will be talking about these 3 trials. IM Power 110 is about whether atezolizumab monotherapy a better agent than chemotherapy in PD-L1 selected chemotherapy naive patients. So first line, and this will be the comparator arm, will be PAM-based chemotherapy in adeno, and gem-based chemotherapy in squamous. IM Power 130 will be looking into whether if we spare steroids, that is, if we use nab-pacli instead of pacli-carb combination, whether this leads to improvement in survival. IM Power 150 was an interesting trial. There were some very interesting outcomes to be looked into, especially as far as the targeted therapy is concerned. So arm A was atezo with carbopac, arm B was atezo, carbopac, bev, and arm C was actually carbopac and bev only. So was there an additional benefit of adding atezolizumab to carbopac or carbopac bev was seen in this particular study? So first the monotherapy one, atezolizumab monotherapy compared with platinum agents uh, uh, or platinum-based chemotherapy. So this was the trial, phase 3 trial, PDL1 selected chemotherapy naive, and stratification factors were sex, performance status, histology, and PDL1 by IHC. Can you hear me?
Yes, sir.
Hello.
Yes, sir. We can hear you.
Yeah.
We can hear you.
Yeah. So the primary endpoint was overall survival in wild type, as I said, wild type population, excluding patients with EGFR ALK mutations. And key secondary endpoints were PFS, ORR, and duration of response as per RECIST. The randomization was 1:1, and this was the result. In TC3 or IC3, TC3 means more than 50% of tumor cells expressing PDL1, and IC3 means more than 10% of immune cells expressing PDL1. So in those, they were the chunk of patients were around 107 and 98 in both the arms, and the prevalence of TC2 and IC2-3 was that TC2 means more than 5% of TC or IC. I think by now you will be clear what is TC1, 2, and 3. So equal number of population. That means as far as the prevalence of PDL1 expression is concerned, both the arms are balanced. Both the arms were balanced as far as the age, less than 65, sex, white, and Asian population, never smoker, non-squamous histology, and performance status is concerned. So the primary endpoint of OS in PDL1 high subgroup was met. As you can see, 6-month OS was 76.3%, and 12-month OS was 64.9% against 50.6%, and the median OS was 20.2 months. The hazard ratio was 0.59, and all the subgroups benefited, and strangely only the never used tobacco or never smoker didn't actually benefit. The chemotherapy arm really did well in that. Other than that, most of the subgroup benefited. So this was one thing. And the subsequent therapies, obviously the arm A had atezo as first line, therefore the subsequent immunotherapy usage was more in the chemotherapy arm, and other than that, rest of the therapies like chemotherapy or targeted therapy were nearly equal. PFS was also meaningfully better, and this was shown in this particular graph. And if we compare the response rates in TC3 or IC3 population, in arm A, the overall response was around 38.3%, out of which minimal of them achieved CR also, and so was in arm B, but overall response rate was 28.6%. Median duration of response was not evaluable in arm A, and it was 5.8 months in arm B for TC2-3, and for TC1-2-3 Again, median duration response was not evaluable, and it was 5.7 months in all the patients. The side effect profile, obviously, with atezolizumab, the side effect profiles were much better. Grade 3-4 adverse events were lesser. Adverse events leading to withdrawal of treatment were also quite less, 6.3 compared to 16.3%. And but obviously, the grade 3-4 immune-mediated adverse events were more as compared to chemotherapy. And so as you can see in this particular graph, very clearly, these upper all side effects are more in chemotherapy arm, and the lower one were more frequent in the immunotherapy arm. So atezolizumab represent a promising first-line treatment option. PDL1 IMpower 110 was a positive study, in which especially in TC3 and IC3 population really benefited with a hazard ratio of 0.59, and the safety profile was consistent with prior observation. It had a favorable safety profile with chemotherapy, and the safety data were consistent with those from pooled atezolizumab. And patients treated with sorry, actually my one of the lines are missing. Anyways, so just for the information sakes, I think most of the panelists and people would be knowing that only 3 immunotherapy agents are approved as a single agent in first line. Atezolizumab is one of them, and the other 2 are pembrolizumab and semipilumab. So we are going to discuss IMpower 150 first, and then we'll go for IMpower 130. So it is a phase 3 study of atezolizumab plus chemotherapy and Bev in first-line advanced non-squamous NSCLC. So in this, the primary motto was to see whether addition of atezolizumab added to chemotherapy Bev combination, and also the other question was whether there was a benefit in replacing Bev with atezolizumab. So the first arm was the replacement arm, and the second arm was all the 4 agents together, and the third arm was the conventional standard arm, carbo, pacli, and Bev. And in the first arm, the maintenance was given with atezolizumab, and in the arm B, the maintenance was with the atezo plus Bev, and the arm C, the usual bevacizumab maintenance. So the co-primary endpoints were investigator-assessed PFS and OSS in intent to treat wild-type population. These were the stratification factors: sex, PDL1, and importantly, liver metastasis. So they were the important stratification factors. What was the logic of combining all these agents? It was Bev inhibits VEGF-mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell responses. Bevacizumab normalizes the tumor vasculature, resulting in much more infiltration of T cell into tumor cell. Bev decreases activity of myeloid-derived suppressors, myeloid-derived stem cells and T regulatory cells, which are immune inhibitory, and enables reprogramming of tumor microenvironment. And chemotherapy as such leads to release of various tumor antigen as a result of cell death. So these were the logic, these were the idea behind combination of all these agents. And the baseline characteristics were well balanced in all the 3 arms, and 14% of patients had liver metastasis at baseline, which are a stratification factor, and 10% of patients had EGFR mutations, and all the 3 arms were balanced in this. And PDL1 expression also was balanced. TC0 and IC0 was also there, around 50% of patient, and rest 50% had at least more than 1% of TC or IC PDL1 expression. So first, the comparator of addition of atezo with the arm containing only BEV. So atezo plus BEV, you can see the landmark OS difference, 12 months, 67% versus 61, 18 months. So there was a 10% or more than 10% difference in all the 3 this thing, and the median survival was around 19.5 months. This was about after about median follow-up of 39.8 months. So the improvement in median OS was meaningful, around 4.5 months, and a higher proportion of patients responded to treatment with BEV atezo in combination with chemo. As you can see in arm B, the response rate, objective response rate was maximum. Strangely, arm A and arm C had near similar response rates. In PDL1 high, obviously the arm A and arm B had much better responses compared to compared to arm C, which didn't have any immunotherapy agent. In PDL1 low, also the arm B had a better response. Arm A and arm C were nearly.
My apologies, sir. You are left with just 3 minutes to conclude your presentation.
Okay. And in no expression of PDL1 and DC0, IC0, again arm B fared better. And this is the similar thing we see, and look at the hazard ratio in PDL1 high and hazard ratio in PDL1 low. In PDL1 negative also the hazard ratio was 0.82. So the interesting thing was when EGFR mutated were studied after taking EGFR TKI, so progressing on EGFR TKI. So even they showed a better this thing, and hazard ratio was strangely 0.59. So this was the first trial which really showed that immunotherapy have benefit in patients having a driver mutation. Otherwise, we don't use immunotherapy in EGFR or ALK or driver target. The patients in which targeted therapies are available, we don't use these agents. So yes, again, the arm B versus arm C hazard ratio was 0.60 with sensitizing EGFR mutation. So again, the response rates were also better. So I'll just rush through. Strangely, liver metastasis thing really benefited with the combination of atezo-bev and platinum-based chemotherapy compared to arm C. I don't know, in a similar fashion, atezo-bev really affects the HCC patients also, but I don't know. But yes, chemotherapy with BEV and atezo combination had a very good impact on liver metastasis. And as you can see in these particular graph, but for arm A and arm C, if you compare alone atezo and BEV, they didn't have any effect. This was the same thing observed in EGFR mutant testing. So I'll just rush through the summary. Again, patient with bulky disease, with high disease burden and low disease burden, both these subsets actually benefited with the addition of atezolizumab to bevacizumab. So the conclusions were it was a positive study in first line with statistically significant and clinically meaningful improvement in both co-primary endpoint of OS and PFS for ABCP versus BCP. Clinical benefit was observed in key subgroups of patients with EGFRL genomic alteration and liver metastasis in baseline with the addition of all four agents, means doublet chemotherapy and Bev and Atezo. Atezo in combination with chemotherapy plus Bev is well tolerated and safety profile is consistent with known safety risks. Additional patient characteristics beyond PD-L1 expression may be considered when making chemoimmunotherapy treatment decisions for non-squamous lung cancer. So these are again the same conclusions being repeated here in the summary. So let's come to IMPOWER 130, in which you had we had the usage of NAB-PACLI instead of PACLI in combination with carbo. So the aim was to reduce the usage of steroids, and the goal of CIT was to create a more favorable environment to maximize potential of immune system to eliminate cancer. So to achieve this aim, there was usage of NAB-PACLI, and arm A was chemotherapy with atezo and with atezo maintenance, and arm B was chemotherapy followed by switch maintenance to pemetrexed. And the interesting thing was, despite the protocol amendment, 41% of patients in the control arm crossed over to atezolizumab. Despite all this, the co-primary endpoint was investigator-assessed PFS, and secondary endpoints were investigator-assessed PFS and OS in intent-to-treat population. Baseline characteristics were similar, and so were PD-L1 tumor expression. They were similar in both the arms. And these were the results. 12-month PFS was in 29, about a double percentage of patient compared to chemotherapy, and median PFS was 7 months. Hazard ratio of OS, median OS was 18.6 months as compared to 13.9 months, and the hazard ratio was around 0.79. All subsets really had a benefit, and liver met at enrollment, actually there was not much of a benefit. Investigator assessed PFS and OS. The OS was not, this was about the mutated subtype, EGFRL mutated. So you need 4 agents or chemotherapy plus atezo-bev combination for EGFRL mutated. And a higher proportion of patients have a complete or partial response in the experimental arm compared to the control arm. So treatment-related adverse effects were also more, and because there was an additive effect of 3 drugs compared to the chemotherapy arm. So the conclusions were IMPOWER 130 was a positive phase 3 study in first line, providing an alternative to chemoimmunotherapy plus chemotherapy regime, checkpoint inhibitor therapy plus chemotherapy regimen for patients with chemotherapy naive NSCLC. IMPOWER 30 demonstrates statistically significant and clinically relevant OS benefit, and it demonstrated a PFS and a higher ORR And OS and PFS benefit was observed across 3 clinical subgroups, and atezo plus chemotherapy had a safety profile consistent with adverse events associated with single agent therapy. So the thing is, all these 3 trials were positive trials. We really have to choose which patients require more number of agents and which patients we can do away with just addition of atezo and chemotherapy, and which patients we can give single agent atezolizumab. So this is left to us to identify the right patients for this particular agents, which is leading to improvement in survival, and not only in not only in wild type, that is patients not having any driver mutations, but also in EGFR mutant when they progress on targeted therapy. If someone can afford and is in a performance status to receive this particular regime, you can use it. Thank you.
Thank you, sir. Thank you so much for this elaborative presentation. Sir, I have one question. So what is your experience of ABCP regimen, and what dose of BEV do you use, sir, in this regimen? I mean, is it 15 according to protocol, or?
Yeah, we do sometimes alter the dose, maybe 10 mg per kg of BEV, sometimes have to use, and but overall, I mean, not much of a difficulty. I have just used it in one patient. Let me be very frank about it. And just yes, BEV dosage has to be reduced. Nothing much has to be was required to be done. It was a manageable protocol, and the patient was not so young also in that case.
Okay. Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, sir. And we move to the last topic of the day, which is weight-based dosing of immunotherapy. Do we all agree? And for this, I would like to invite Dr. Santosh C, medical oncologist. So over to you, sir.
Yeah, thank you very much for inviting me. Me being the last speaker, I will be very precise and crisp. You should not scold me. I would be completing my seminar in 5 minutes. And could I share my screen? Yes, thank you. I'll just share my screen in a minute. So first of all, I bring greetings of Ugadi from Telangana and Hyderabad. So we celebrate across India. It's our diversity. So I'll go straight to the topic. What is weight-based dosing of immunotherapy? Should we use on a weight base, or it should be on the flat dosing that many recommend? So my topic would be not liking by the sponsors of the meeting. I don't know how would Priyanshu generalize it. So whatever it is, we are here to speak the science. So I would just tell what we have data supporting, what we do not have data. So first of all, we come for a nation where we account for each and every paisa. So we need a mileage before choosing a car and anything. So there was a study, very interesting study conducted at Tata Memorial. They have seen out of all patients who have an indication for immunotherapy, they found out that only 1.6% of eligible patients who were requiring immunotherapy finally took immunotherapy. So this is the problem in India with the current presence of costs, which are very, very high of immunotherapy. But we have very high incidence of oncology cases. How do we deliver these products to these oncology products? This is the essence of my talk. So we employ a lot of cost-cutting measures, whether we work in a government setup or private setup. So what we do, we give lower dose. For example, abiraterone, we use lower dose. We use less frequently dosage and shorter course of treatment. We try to complete, especially the breast cancer trial, where even 9 months of adjuvant therapy sometimes is sufficient. And we use some strategies to improve oral drug absorption, especially in case of serotinib and abiraterone, using low-fat diet and all. And we especially employ another agent to enhance the availability. The example of venetoclax, where we use antifungal fluconazole to increase the dose 4-fold time. We use only 1/4 dose. Giving an alternative agent And if we have a strong government dedication, as we have seen with the approach of ART and ATT, they are given free of cost. With government support, we can definitely go ahead, as we have seen a decade change in the costing of tyrosine kinase inhibitor. For each molecule, we have around 5 to 6 companies now. So that is welcome step in India. We need a lot to hear. Maybe my guess is maybe in 10 years down the line, the scenario that was with tyrosine kinase inhibitor 10 to 15 years back would be with immunotherapy. So with this premise, let's talk what is the important difference in principle of immunotherapy and targeted compared to phase 1 trial of conventional chemotherapy. So in phase 1 trial of previous conventional chemotherapy, it's based on maximal tolerated dose based on side effects. But for immunotherapy and targeted therapy, the side effects do not occur. So also the important thing is receptor occupancy and toxicity are not dose related. So this is an important thing. So my point is the principles we use in conduct of conventional chemotherapy are not equivalent to conduction of phase 1 trial of immunotherapy and targeted therapy. We do use an alternative strategy such as receptor occupancy to see how much is the tolerated dose, but this is only in the preliminary step. There is no clear understanding what should be the best method to conduct trial of immunotherapy and decide dose in phase 1 trial. There lies the important problem. So because of this, to circumvent all this, what a lot of companies during the initial researchers do is they empirically use a random flat dose. So this is the background of choosing of dose of immunotherapy. So low dose immunotherapy is the need of the hour. As we know, immunotherapy is a immunoglobulin antibody molecule. The T-half is pretty long. Even though the T-half is long, lot of we use 2 weekly, 3 weekly as recommended by FDA and Indian guidelines. And as I told, phase 1 trials are different compared to targeted and immuno-oncology dosage. And we have seen when desperate circumstances occur, we have to take desperate measures. As we have seen the dosing of pembrolizumab, it was initially only given very frequently. Later, they increased to 4 weeks during and 6 weeks also during the COVID pandemic. So there is a scope, but the regulatory and the pharma companies should help us so that we can serve our needy patients much better. As you can see, this was a published trial. This was a review that was published from Tata Group, where they have seen that even nivolumab, pembrolizumab, and atezolizumab in increasing dosages, that is 0.1 as low as 0.1 mg per kg, would show efficacy of 30%, which is equal across all agents. So we should give a dose that is sufficient to target and inhibit the receptors that is possible with even minuscule dose of 0.1 mg per kg. We don't know what is the magic number, but we are giving the dose that is almost 10 to 20 times higher than what is required. So this is one important thing, and this is the data backup, where you can see across various dosages range, the responses are pretty okay. So even we have a trial data that supports low dose immunotherapy. So this is a recent analysis that was published by Dr. Amol and Dr. Ian Tannock. So where they have seen various immunotherapy agents, the current costing of conventional FDA approved dosages, based on the retrospective analysis, they have formulated a nivolumab dose of 0.6 mg per kg every 4 weeks, pembro of 1.6 every 6 weeks that we have, and atezo every 6 weeks. So you can see this staggering figures where 90% cost reduction, 86% cost reduction, 95% cost reduction. If single patient use, we can use 14 patients use in the same cost. So this is very staggering difference. So how should we able to go to this era? So the problem of low dose immunotherapy is the giant pharma industry lobby that prevent us conducting these trials. And there are legal issues whenever we give low dose therapy. If unfortunately the patient progresses, then we would be no backup. So this is the need of conduction of investigator initiated clinical trials at the academic, and there is the requirement of cooperation of various oncologists across India. So the problem occurs if the patient progresses on low dose immunotherapy, we should have a proper ethical approval before initiating this thing. So this is the importance of proper conducting an investigator initiated trial. So the important thing, the pharma company is always smart. So they are one step ahead of this. So we employing the strategy of low dose immunotherapy. I have come across two important occasions. Recently, during a prescription of abemaciclib, I found out that the dose for all mg is same, 100 mg, 150 is the same. And also regarding procurer of venetoclax from the official sources through US, I found out that the cost of 10 mg dose is equivalent to 400 mg dose per month. So they have changed their costing strategy from cost per duration rather than dosage. So one patient, 1 month, either he takes 10 mg or 400 mg or 500 mg, the cost should be there. These are the approaches of pharma industry. So we should act as a cohesion for help of the patient so that the patient would be beneficial. So always more is not always better. We have to choose the right spot, the correct dose. I know lower dose is efficacious, but we should use in a protocolized way. With this, I would end my presentation. I would thank the organizers for giving me this opportunity, and I hope I completed in time.
Thank you. Thank you so much. And now I would like to invite Dr. Priyanshu for the closing remarks.
Thank you, Dr. Santosh. I think so that was an eye-opener. And definitely, I would say with this approach, if we can provide immunotherapy to a lot more patients, we would be having, a better patient care overall in India. And I think so we also would like to have some investigator-initiated trials. I think so you can take the lead in that, uh, you know, and I think so we can pool our data also. Just it's not just that if you are in a private setup, then you have to, give more of this immunotherapy. But definitely, I think so, and I guess within 2 years or so, we'll be having some generic immunotherapy patent coming after the expiry of patents also. So I think so that would be also a game changer. So thank you, Dr. Santosh. Thank you so much for this wonderful presentation. And I would like to thank Dr. Piyush, my co-convener. I would like to thank all the team of Horizon, and I would like to thank all the panelists and all the attendees for sparing the time on a Saturday evening. And I think it was a little longer than expected. I mean, 4 hours is a lot of time, but I had so much of topics in my mind, so I had to, club it in the required time. So thank you everyone for keeping their presentations to their stipulated time, and thank you and have a wonderful weekend.
Thank you everyone for joining, and good night everyone.
Pleasure.